So greetings, ladies and gentlemen, très honorable sénatrice Jane Cordy, Madame Biba Tinga, présidente de l'Association Anémie falciforme du Canada, avec qui j'ai eu le plaisir de converser un peu informellement et qui me rappelait que sa mère est une diplômée de la Faculté d'éducation de l'Université d'Ottawa. Alors, bienvenue. Monsieur Joël Arden, également, député provincial Ottawa-Centre, chers distingués invités, chers collègues, chers amis, mesdames et messieurs, bonjour et bienvenue à vous toutes et à vous tous. C'est un grand plaisir pour moi de vous accueillir sur notre campus pour cette conférence programmée à l'occasion de la journée de sensibilisation à l'anémie falciforme. Permettez-moi tout d'abord, comme il est coutume de le faire, de rendre hommage au peuple algonquin, gardien traditionnel de la terre sur laquelle se situe l'Université d'Ottawa. Nous reconnaissons le lien sacré de longue date l'unissant ce territoire qui demeure non cédé. We pay respect to all Indigenous people in this region from all nations across Canada who call Ottawa home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. As mentioned, I'm really delighted to be with you today on behalf of Sylvain Charbonneau, Vice President Research and Innovation, to launch this U-Ottawa-hosted event jointly organized by the Interdisciplinary Centre on Black Health and the Sickle Cell Disease Association of Canada. The conference aims to bring together researchers, policymakers, caregivers, patients, and community leaders to exchange on this life-threatening disease affecting thousands of Canadians and to mobilize knowledge for increasing awareness throughout the community at large. It is a testimony to Professor Jude Mary Cénat's leadership at the helm of the Centre to have gathered today so many stakeholders to this important forum, including government officials, as well as national and provincial representatives of the Sickle Cell Disease Association from Alberta, British Columbia, Manitoba, Ontario, and Quebec. The Interdisciplinary Centre for Black Health's mission of informing public health policy and of bringing health disparities and gaps in care affecting Black communities to the forefront is fully aligned with the University of Ottawa's strategic research approach founded on the core values of relevance, equity, impact, and inclusion, as well as in the pursuit of excellence. L'anémie falciforme touche les communautés identifiées par la recherche comme étant bien moins desservies en matière de soins de santé. En diffusant le plus largement possible les avancées des connaissances scientifiques sur cette maladie encore trop peu connue, cette conférence contribue indéniablement par la mobilisation des connaissances à faire avancer la santé et le bien-être tout au long de la vie et à promouvoir une société canadienne plus juste, parce que plus équitable en matière de soins de santé. Je profite et je termine ce court discours, encore une fois, pour saluer l'ensemble du travail de recherche unique accompli par l'équipe du Centre interdisciplinaire sur la santé des Noirs, et ce, en moins de 2 ans. Le Centre est un espace de recherche et de formation de premier plan qui reflète l'excellence de la recherche développée au sein de notre université et qui contribue à améliorer la vie de toutes les Canadiennes et de tous les Canadiens. Je vous souhaite une excellente conférence. Malheureusement, je ne peux rester des vôtres tout l'après-midi, mais encore une fois, merci à l'équipe du Centre, merci à vous tous et à vous toutes pour votre présence. Et je passe la parole à mon collègue, puis-je le dire, and friend, Jude Mary Cénat. Thank you.
It's important to note, like the center benefits a full support, I can say, from the research office at the University of Ottawa. It is now a pleasure to present. Usually people say, on Sickle Cell Disease, people say warrior, and I think she's really the warrior. And I think people from the let's call it the Sickle Cell Disease community in Canada, they really have a warrior to defend them. And I'm talking about the president of the Sickle Cell Disease Association of Canada. She's a parent of an adult living with sickle cell disease. She has a unique understanding of the needs of the families, but also children dealing with the disease. Je ne vais pas dire plus, mesdames et messieurs, je vous invite vraiment à applaudir Biba Tinga.
Good afternoon, everyone. Bonjour tout le monde. Honorable Senator Cordy, MVP Alvin, Madame Lagacé, warriors, guerriers. Before I start, I'm going to say something to you, very personal. Look at this flyer. You see all the people on the flyer? Look at their titles. Doctors. Look at my name. I'm not a doctor. I'm not a medical doctor. I don't earn a PhD. I didn't earn a PhD. And this morning I called my mom early in the morning, and I told her that today I was going to be on a podium speaking with people who have, who are physicians and everything. And I told her that, and I'm going to do it from this university where she graduated with a PhD in 1988. My mother is the first woman to bring a non-medical PhD to Niger, my birth country. And my mom says to me, it's good, Biba, you've earned that. You've earned the PhD of life. It's been 35 years. 35 years of dealing with the most debilitating disease, the most painful disease that has killed so many people in our community. And for that, you are an expert by experience. So I'm very grateful for this podium today. Warriors, if you have sickle cell SS, sickle cell SC, sickle cell beta thalassemia, if you want, if you can, please stand up. Please. If you are a caregiver, you care for somebody with sickle cell disease. If you have a child, if you have a partner with sickle cell disease, stand up. Thank you. And unfortunately and sadly, I would like to say, if you've lost a child from sickle cell disease, please stand up. And let us acknowledge today that some people are still here. I'm so sorry. And the pandemic is over, right? Now we get to come outside, now we get to meet in person. It's our first in-person activity since the pandemic. And during this pandemic, our community had to shelter more than any other one because they are very, vulnerable at risk. But at the same time, we were the most forgotten one. I can speak from experience that my son had to work for 60 days before he can get a medical leave and stay home. I saw people with asthma, with high blood pressure, given a medical leave to stay at home. He couldn't get it because they said sickle cell was not on the lists. So we had to create our own system to protect him. His young brother had to drive him every day, and I took on going to the supermarket to buy his food. But he went to work. He wore a mask, and he washed his hand for 60 days, when nobody knew what could happen to him. I'm telling you this just to tell you about the state of sickle cell disease in Canada. Supportive care. If you have sickle cell disease and you live in Canada, you have two treatment options. Hydroxyurea, which is a cancer drug, and blood. That's it. For the past 45 years, our community has left with only that, antibiotics, painkillers. And yet, when people go to seek care, they face a barrier, being called drug seekers or waiting for long hours in the ER before having access to care. So today, as we stand here, this is why we keep raising our voices, amplifying our voices to raise awareness about this disease and to let you know what are our needs so that together, all of us as Canadians, we can find a solution. We know what sickle cell disease is in Canada because we've had good support and strong allies. Thanks to the bill introduced by the dear Senator Cordy, that I can now call Jim. The bill S-211 became a law in December as I was becoming the president, December 2017, and we got it. That makes Canada the first ever country in the world to pass a law to recognize June 19 as Sickle Cell Awareness Day. Thank you, Senator. But we have to continue the work that she has started. We have to continue on the same path because people are still suffering. To this day, we don't have enough research done. I'm so grateful for the work that Dr. Jude Mary Cénat is doing. And now we have doctors like Dr. Dryden who came again on the board, and we are going to continue to do more. We need data generated from the community to show the state of the care, the quality of the life. I really get very upset when people say that, oh, people are living longer now. Yes, but where is the quality of life? I'm stronger than my son sometimes. I have to pick him up from work every day. I have to help him sometimes for some stuff that he should be able to do for himself. Sometimes I wonder if the treatment is working. And unfortunately, we've been burying our kids under the age of 50. 50 is too young to die in Canada. It's too young to die in Canada. We gotta do better as Canadians. We have so many barriers. And I tell you today, we Canadians have to sit in very uncomfortable spaces together. We have to have very difficult conversations together so that we can fix this for ourselves. Because yes, sickle cell affects people coming from communities that are considered to be marginalized. But you know what? Now, it can affect anybody. We have people with blue eyes and blonde hair having sickle cell. So, we need to work as a community. You have my speech here in French or English. The one that went out to the community today, I would love for you to hear it. Today you're going to hear about the work that we've been doing with Dr. Smita Pakhale, the first physician to come and hold our hand and say, I know what you need. You've been asking for the registry. I am going to do it with you. And we got it done. We've started the National Registry for Sickle Cell Disease. You're going to hear from Dr. Bryan. She's going to talk about the ER. And you're going to hear from Dr. Simpson, who is working every day to treat people with sickle cell disease. I want you to pay attention. And when you leave this room today, I want you to become an ally. Thank you.
The United Nations made this day Sickle Cell Disease Awareness Day, but Canada, as Biba said, was the first country taking a bill to make, voted a bill to make this day officially a National Awareness Day in Canada. And the person who introduced this bill was Senator Jane Cordy. And it is my pleasure to introduce Senator Jane Cordy.
I do have written notes, but before I start that, I just have to talk about Biba for a moment. She is definitely a sickle cell warrior. She's passionate and compassionate. She's caring. She's driven, always driven, to make things better. And every time I'm at an event with her, she just keeps pushing and pushing and pushing, and that's what we need. And I'm proud to be with you here today, Biba, and I'm proud to call you a friend. And your mom was absolutely right. You are a doctor of life. Thank you for having me. I would like to start by acknowledging that we're gathered here on the ancestral and unceded lands of the Algonquin and Anishinaabe nations. I'd also like to welcome everyone here today on this National Sickle Cell Awareness Day and express my gratitude to the Interdisciplinary Center for Black Health and the Sickle Cell Disease Association of Canada for organizing this conference and inviting me here today. And it's wonderful that the sun is actually shining, because that's what it's like when we all get together to make things happen. I must say that it's wonderful to be able to be together in person after years of limited contact and virtual gatherings. Nothing can replace the sense of community that you get when you have people in the room. And as I was saying to people earlier today, it's not just listening to people who are speaking, It's going for coffee and standing and talking to people and hearing their experiences. And that's where I think I've learned most, is just by listening and talking to people and hearing the story. I'm a senator from Nova Scotia, and my journey with the sickle cell community began almost 10 years ago with an information breakfast for parliamentarians on Parliament Hill, hosted by the Sickle Cell Association of Canada and Member of Parliament Kirsty Duncan of Toronto. And I'll say that prior to that breakfast, I had not heard of sickle cell disease. The people that I met that morning 10 years ago, and the heartbreaking stories that were shared, were so passionate and touched me, so that I was motivated by the end of that breakfast to help in any way that I could. And that was the beginning of my relationship with the Canadian Association. At that time, Luancy Ajay was the president, and today I'm so lucky to be working with Biba Tinga, Dr. Biba Tinga. As I said earlier, she's one of the most passionate, the most hardworking people that I know. Biba is making a huge difference in educating Canadians about sickle cell disease. When they first came to Ottawa, the National Sickle Cell Association wasn't only looking to educate people and parliamentarians about sickle cell. They were also hoping to find allies on Parliament Hill to work in helping to educate Canadians and to raise awareness of sickle cell disease across the country. The idea was to follow the lead of the United Nations General Assembly's resolution that declared sickle cell disease as a global health concern. It designated June 19th as the official day to raise awareness about the disease worldwide. I introduced, as Biba said earlier, I introduced a Made in Canada approach to recognize June 19th as National Sickle Cell Awareness Day in Canada in the Senate in the spring of 2015. A federal election was called not long after that, which, as we say on Parliament Hill, it killed the bill. The bill was no more. But when we were called back after the election, I introduced the bill again in the fall of 2015. Over the next 2 years, our bill slowly worked its way through Parliament, but finally, in the fall of 2017, 2 years later, it became law. And I have to tell you, sometimes I would be shaking my head, talking to parliamentarians in the Senate and the House of Commons, saying, like, this bill isn't that difficult. Let's get it passed, but that's the way Ottawa works. I was encouraged by the speeches of my colleagues, and I am forever grateful to my fellow senators and MPs who unanimously supported the bill, particularly my own MP, Darren Fisher, who sponsored the bill in the House of Commons. And I have to tell you that usually when you have what we call a private member's bill, you're phoning the House of Commons saying, like, would you please sponsor my bill? Because it's a lot of work when you take on the job of sponsoring the bill, either in the Senate or the House of Commons. That day, my office got 5 phone calls to say, could I please sponsor your bill? I hear it's going to be voted on, and when it comes to the House of Commons, can I have it? Darren luckily happened to be the first one to phone because he was my MP, so it would have been pretty hard to say no to him. So as you know, Canadians celebrated the first official National Sickle Cell Awareness Day in 2018. And as Biba said earlier, we were the first country to officially recognize Sickle Cell Awareness Day. I tell the story of this legislation for 2 reasons. One is to remind you that your outreach, your advocacy efforts, whether they're in your community, your local level of government, provincial government, or even the federal government, does have an impact. It makes a difference. So if you're talking to people, all the women in my bridge group all know about sickle cell. My family all knows about sickle cell. And you know, it's interesting because I'll have some of the people that I've spoken to just socially come up to me and say, I was out the other day and I heard somebody talking about sickle cell, and they said they joined in the conversation. And it's just the knowledge, like when people are aware of it, it makes a huge difference. The second thing to remember is progress can be slow, and at times it can be very frustrating, and at times there are setbacks. You think you've moved 5 steps forward, and then you're going back a little bit. But I feel that as a senator, I feel that trying to get legislation through, and sometimes when you're not within the system, it's even more daunting and more frustrating. But remember, the actions that you take, the speaking that you do affects change, and even the worthwhile causes take a long time. Distinguished guests, when it comes to the discussion of sickle cell awareness, particularly on Parliament Hill, I must acknowledge the great Jean Augustine. Some of you in the room may know her. In 1997, she was the first person to raise the issue of sickle cell on Parliament Hill. And to highlight how little sickle cell was known, the health minister at the time told Jean that he didn't know what sickle cell was. But to his credit, it was Alan Rock, some of you may know Alan Rock, to his credit, a week later, he told Jean that he had gotten a briefing from his department on sickle cell disease. And it was MP Kirsty Duncan who helped to inform me about sickle cell. The conversation around sickle cell that started with Jean Augustine continues today. Last Wednesday, the Senate's African Canadian group hosted a parliamentary information breakfast, not like the one I attended 10 years ago. And the MPs and the senators I spoke to after last week's breakfast were affected in the same way that I was affected at the breakfast in 2013. So the number of allies on Parliament Hill are growing. And I am encouraged that the conversations will continue to happen. As I look around the room today and see all of us here together, I must add that I had the good fortune to attend the Sickle Cell Awareness Group of Ontario's annual Hope Gala and Awards ceremony on Saturday night, and after several years of galas being canceled, I was reminded that night of how strong and vibrant the sickle cell awareness community is becoming. And I see that strength here today. As I wrap up, I just want to express how grateful I am to everyone who is in this room today. You are helping to raise awareness of sickle cell. You're helping to share your knowledge, and you're helping to support one another. And I once again thank the Interdisciplinary Centre for Black Health and the Sickle Cell Disease Association of Canada for organizing this important event today on this Sickle Cell Awareness Day. We have come a long way since I started my journey with sickle cell awareness, but there is still a lot to do, as Biba said earlier. But when I see the people who were on Parliament Hill last Thursday, and in Toronto on Saturday night, and here at the University of Ottawa today, I know that we are blessed with advocates who share Biba's passion. Thank you, merci, miigwech.
In the US, there are an estimation of 30,000 people with cystic fibrosis, and an estimation about 90,000 people with sickle cell disease. But cystic fibrosis when cystic fibrosis receive $3,000 of research, sickle cell disease receive $800 in research. From foundation, so this is from public fund, from private foundation, when cystic fibrosis receive $8,000, sickle cell disease receive just $100. I was like very curious, and I tried to see the figures in Canada, and the gap is more important. So this is why it is important to continue to talk about research, and because without research, it is difficult to find the solutions. Maintenant, j'ai l'honneur de présenter quelqu'un, parce que dans ces événements-là, c'est extrêmement important qu'on entend les chercheurs, qu'on entend tous ceux qui sont concernés par la question en parler, mais c'est aussi important d'écouter des personnes qui vivent la condition de pouvoir en parler. Et j'ai le plaisir d'introduire M. Ulysse Guerrier, qui va venir vous témoigner, et j'aimerais vraiment un taux d'applaudissement pour lui.
Merci pour cette introduction. Bon après-midi, mesdames et messieurs. Good afternoon, everyone. My name is Ulysse Guerrier. I'm a sickle cell warrior, meaning I live with sickle cell disease. Sickle cell disease is an inherited blood disorder that affects millions of people around the world. About 6,000, that's the statistic that we have, about 6,000 people that accesses services in Canada living with sickle cell disease. It's a long life illness. The condition causes severe pain, organ damage, even death. For those who don't know what sickle cell is, it's basically the shape of the red cell is abnormal. Instead of looking like an oval, it looks like a crescent or a banana. So when it goes to a vessel, it blocks. Oxygen doesn't go there to that region, and that region basically died, deprived of oxygen. That's essentially what sickle cell disease is. We have a few doctors here today that can explain in greater details what sickle cell is. Knowing what sickle cell is, the biology of it, it's all good. It's good information. We're in a university, and that's good knowledge to have. But what does sickle cell look like? That's the question. Most people, if you see me walking on the street, you would not know that I have sickle cell disease, right? Because it's invisible. It's internal. Everywhere we have blood, wherever blood circulates, we can have a crisis, meaning you can have pain in that region. I'm talking to you today, I'm in a lot of pain, but none of you guys will be able to know. And something ironic that happened, I started a crisis last night because of the change of the temperature from coming outside to inside the hotel room. There was AC, and the cold, because I take off my clothes, and the cold got into my legs, and I started having a lot of pain. And I couldn't sleep. Sleep deprivation is not a good thing. It's not a good combination for recovery. So I had to take a lot of medication. Some of the medication that we take is opioids, strong opioids. And that gives us the stigma of being drug seekers or drug addicts, which is not true, but who gave us the prescription of those medications? The same people that call us drug seekers and drug addicts are the same people that give us the drugs. But we need those drugs. Without those drugs, we can't survive, we can't function. I would not be here today to talk to you if I didn't have those narcotics that I need to function. Let me kind of go back and tell you guys a little bit about myself. I was born with sickle cell disease. I was diagnosed at the age of 2. My parents are from Haiti, I'm from Haitian descent. I was born in Toronto, raised in Montreal. I was born in the 70s. In Canada, we considered to be industrialized country, one of the biggest country in the world. And guess what? I was not diagnosed in Canada. My parents went to Haiti on vacation, and that's how I got a crisis, and I got diagnosed in what we call a third world country. How is that possible? How does that make sense? That Haiti or anywhere in Africa or in the Caribbean or South America, they know what sickle cell is, and in Canada we didn't know what sickle cell is in the 70s. We all have the same information. Why is that? I lost one of my older sisters to sickle cell disease when she was 7 months old. It was devastating loss to my family. Because of it, my mother was very, even overprotective of me. Because when my sister passed away, due to sickle cell disease, what we didn't know at the time, she saw the same signs in me growing up. Coming up as a baby, I was crying all the time. She couldn't, make me stop crying. And I didn't, like the general growth of a baby, I didn't achieve that in the time that we were supposed to achieve those things. So she saw signs of my sister's illness in me, and she kept going to the hospital, asking the doctors, what's wrong with my baby, what's wrong with my child? And they gave me all kind of diagnosis, misdiagnosis, and they couldn't find what sickle cell was. But they couldn't find what was the issue. And like I was saying earlier, I was diagnosed in Haiti by Dr. Yvette Boni, for those who know who Dr. Yvette Boni is. She's a very renowned doctor, hematologist from Haiti that migrated to Quebec, Montreal, Quebec. And she was the doctor that diagnosed me there, and she became my doctor when we moved back to Montreal. And she was like a second mother to me, and due to her good care, I'm here today. Because in those times, there was little information about sickle cell, and she was a trailblazer, an advocate for sickle cell disease. And even though she retired today, we're still celebrating her, at the gala, what was Saturday? Yeah, at the gala Saturday, we gave homage to Dr. Yvette Boni. She did tremendous work. When I was 25 years old, I lost my younger brother to sickle cell disease. He was 23 at the time. 23. It's a very young age. 23 for somebody to die of sickle cell disease in Canada. It's shocking. And my brother passed away from what they call the silent stroke. And to diagnose silent stroke, you have to do an MRI of the brain. And thanks to the newborn screening, now we know, we can detect if a baby, or even through the pregnancy, if somebody carried a sickle cell. So having those scans done at a young age and continue doing those things helps to be able to establish what are the costs of treatment that we can do to help people with sickle cell. I'm talking about, I was diagnosed in the 70s, and now we're in 2020, in the 2020 era, and the treatment for sickle cell disease is pretty much similar to what it was in the 70s. Doctor was talking about cystic fibrosis. Treatment for cystic fibrosis from the 80s, when we start hearing about it, to today, it's like night and day. There's a lot of changes, there's a lot of investment, there's a lot of research that's been put there. Why is it that two illnesses that are comparable in terms of numbers of the population, the people that it affects, one has resources and the other one doesn't? I'm asking you guys that question. Why? having sickle cell disease, I'm faced with a lot of mistreatment, misunderstanding from doctors, nurses, who do not understand or do not want to understand how to take care of us, how to have empathy, how to care for a fellow human being. I also face racism, stigma. Sickle cell disease is often called invisible disease because you can't see what's happening inside. Whether or not I'm hemolyzing, what is my blood count. Sickle cell is constant, it's always there. I'm always in pain. And when people will acknowledge our pain, understand what our pain is. Recently, I was hospitalized for what was supposed to be, what they call it, routine surgery. I was to have a biopsy of my shin because complication due to sickle cell, my bone marrow is pushing against my bone and it pierced my bone and there's a hole in there and the bone marrow actually leaked out. This thing didn't happen overnight. It took about 10 years to get to that point. But from the beginning, I've been telling doctors, I'm having pain in my legs, I'm having pain in my legs. And, you know, is it your typical sickle cell pain? Pain is pain, it feels like pain. Like I cannot describe if it's the same, but it's similar, but it's pain. It's not normal that I'm having pain like this for over 10 years and you guys are not doing anything. So one of my doctor, which is one of the doctors that I have that was that had compassion, care about his patient, whether you're black, white, yellow, he actually treated all of his patients the same. And he took it to heart and said, you know what, let me do all the tests that's possible and let's find out what it is. Did an MRI and they discovered that the bone marrow pierced my bone and then leaked out and created this mass that they see. But they didn't quite know what it was. It wasn't certain. And what they thought it was, it's something called osteomyelitis, which is an infection of the bone. Which it wasn't, but that's what the doctor thought it was. So I was scheduled to do a surgery, which was supposed to be a biopsy, take a little sample of the growth to find out what it was. During the pre-assessment, went to talk to doctor because of COVID. Now we do a lot of medical appointment over the phone or via Zoom, whatever. So during the assessment, I'm talking to the doctor and I explained to the doctor what medication I'm taking. I'm taking what they call fentanyl, which is like a drug that has the bad reputation of being the drug of choice for drug addicts. And I also take something called oxycodone, another drug, poster drug for drug addiction. So I'm telling him, my history and everything, and I told him, I have sickle cell, so I would like you guys to take care of me. It's not like we're asking for special treatment, but I'm asking for consideration for my illness. So things that you do with the general population, you cannot do it the same thing with us because we are different. And they're always talking about patient-centered care. But when it's time to address patient-centered care, they don't address it. They don't do it. It's a word that sounds good, but you don't you use it when it's valuable to you, but when it's time for you to use it for the patient itself, you guys don't do that. Or the doctors don't do that. So to make a long story short, so I told them, I need to be to have special precaution. The operating room, I have to be warm at all times. If there's change of temperature, I can have a crisis while I'm doing the procedure. And we have to have blood ready in case I need blood. So thankfully I did a treatment before the procedure. and I requested to be able to stay overnight under supervision to make sure that everything's okay before I get discharged. And I also saw an anesthesiologist that came and, you know, talk about your history, talk about the medication that you take. And I asked him for a request, which was, I want to see an anesthesiologist that I know, that I've seen before, that knows my history, that I'm comfortable with, because they know my history and they know me. Because of that, the treatment they will take care of me. They'll do that special. It's not special treatment, but they will take consideration of me. This doctor was offended, and he said, every doctor in the team are very capable of doing the job. You don't have to worry about it. Whoever is there, they'll take care of you. I said, that's not what I asked for. I just asked for a simple request, which is, I've been going to this hospital for over 25 years. I just need to have somebody that knows me on your team that could be there that day. Deny my request. The doctor that doing the surgeon doing the procedure denied my request. So I did the procedure, thank God. The anesthesiologist that was there is somebody that I actually know. She was the head of anesthesiology. And they wanted to give me something, it's like similar to epidural. So they give you a shot and then it numbs your lower part so that they can do the procedure so you won't feel the pain. So I said that I'm not comfortable with that procedure. I would rather get general anesthesia because I'm used to it. I've done it before and everything went well with that. We had to debate like over an hour for me to get general anesthesia. So they sent a fellow. I said, no, I want this. They sent a second doctor, a third doctor. And then the head anesthesiology came and then she recognized me. She said, oh, Mr. Guerrier, okay, so what seems to be the problem? Like, what's the back and forth? I said, well, I asked to be able to have general anesthesia because I'm comfortable with that. I'm not comfortable with the other treatment that you guys are proposing. And my case is very complicated. If there's something called like, 1 in a million, 1 in 1,000, 1 in whatever, I'm the one. It always happens. So why don't you consider that fact? So she said, okay, I know you, like, you would not be, you're not a difficult person with experience, I know you. So let's do what you asked for. We'll have general anesthesia, we'll have you to be comfortable, we'll give you pain meds. So she basically took care of me. What I asked for, which was simple to do in the first place, we were able to do that. After the surgery, I got discharged. Because I'm under anesthesia, so I'm not really 100% there. So I got discharged, I'm like, okay. I asked to stay overnight, and then, so they denied. I'm not in the mood to fight, let me just go home. So I went home. When the anesthesia wore off, the pain went through the roof. There's nothing I could do to decrease the pain a little bit. We had to rush to emerge. Went to emerge, get to the hospital, etc. So the surgeon, and so actually I called him. I said like I have to go back to the hospital because like the pain is out of control. And so he said go to emerge. So what I was trying to avoid, it's exactly what happened. So I ended up going to the hospital, going to emerge. I stayed there for a month. For a month, guys, for something that's called simple, normal procedure. So all this could have been avoided if they had just listened to me in the first place. And this is one of the biggest issues that we face, not being heard. So does any of you ever had like a broken bone? By show of hands, broken bone. Okay. Do you guys remember the pain that you felt? Do you guys remember the experience of being in a cast? The itchiness? Imagine that experience, you living that every day. And that pain is nothing compared to the pain that actually I go through. I broke bones before, and it doesn't even, like I actually broke a bone, I went to the hospital, they rushed to take care of me better than when I'm in a crisis. And I need urgent care right away. They took care of me faster with a broken bone than with a sickle cell crisis. So if you can imagine that type of pain, you go through that every day. And they have no solution for you. The only thing they can suggest is pain control. And that pain control is not even doing the best job. It's manageable, but it's not doing the best job. There's no cure, by the way. There's no cure. So the financial burden of living with sickle cell disease can also be immense. Treatment and medication can be expensive, and many people living with sickle cell disease are unable to work due to the illness. The government hasn't considered sickle cell disease as a disability. No government funding for sickle cell organization. So as you guys can hear from my story, living with sickle cell disease is a heartbreaking experience. It's a daily battle. And that can take a toll physically, emotionally. So we're gonna watch a short clip. Michael? And when we come back, I have a serious question that I would want to ask each and every one of you. Can somebody grab
What are
this
some of the
mic?
challenges that you face using sickle cell disease? Things that are hard.
Not believing that I have sickle cell. Not believing that I have pain.
What about like day to day? What's hard about just every day?
I always have pain.
You always have pain every day?
Yeah.
This is Sophie. She was 10 years old at the time. And she was essentially explaining that she lived with sickle cell disease. And she has pain all the time, every day. And when she speaks to the doctors, she's describing the type of pain that she has. She says that the pain moves. And the doctor look at her funny. What do you mean the pain moves? Well, everywhere you have blood circulating in your body, you can have pain. You can start, the pain could start in your shoulder, go to the arm, go to the left side, like, you know, anywhere you have blood circulating, you can have a crisis. So, this is Sophie. If Sophie was your child, what would you do? That's a question I'm asking every one of you. How far would you be willing to go to get someone like a doctor, a nurse, to listen to her and to believe that she is in pain? Today is June 19th, National Sickle Cell Awareness Day. I urge you to take a moment to think about those living with sickle cell disease, like Sophie, myself, and everybody that stood up today that has sickle cell disease. And there's many more in your communities. So would you ask, what can you do to help? You can help by raising awareness and support those affected by donating blood, give money, we all need money, and by volunteering for any sickle cell organization near you. Thank you for listening.
Luancy Demesmin, who's going to sing a song for us. We've heard her before, she's phenomenal, and please fasten your seatbelts. Luancy, please come.
Amazing grace, how sweet the sound that has saved a wretch like me. I once was lost, but now I'm found. Was blind, but now I see. 'Twas grace that
see, that was amazing. At this stage, I'd like to call Dr. Idrissa Beogo, who's going to present the first panel. Dr. Beogo, please.
Good morning, everyone. Merci et bienvenue à cette conférence très informative et très instructive. On a assisté à beaucoup d'informations. Je vais essayer de courir pour rattraper le temps. We are short of time. I will try to do my best, and faire en sorte que le panel se déroule dans le temps pour que vous puissiez poser énormément de questions. Pour ce faire, je me présente d'abord. My name is Idrissa, and I'm a nurse by profession, and I'm assistant professor in the School of Nursing in this university. Je vais commencer par présenter Dr. Simpson. Dr. Simpson est pédiatre, hématologiste de McGill, et Dr. Simpson va nous présenter the changing the face of sickle cell disease, the evolution of sickle cell disease therapy. So, elle va essayer de nous mettre en lumière les différentes thérapies qu'on observe actuellement, qui sont en cours actuellement. Vous savez que M. Guerrier a tantôt parlé des différents aspects en lien avec le fait que le traitement, l'accès aux soins assez difficile, était quand même difficile, s'améliore maintenant. Elle va nous présenter faire une présentation dans cette perspective-là. Deuxième présentatrice, Dr. Simpson peut peut-être. Can you? Yeah, okay. Please welcome Dr. Simpson. La deuxième personnalité que je voudrais présenter, Dr. Jude, as well as Dr. Biba already talked about her. Dr. Pakhale is also another warrior. Comme Dr. Biba l'a dit, Dr. Biba, selon la sénatrice Cordy, elle fut celle-là qui a participé à mettre en place le registre. C'est très important pour les chercheurs. Les chercheurs qui sont dans la salle le savent très bien. Je voudrais que vous l'applaudissiez beaucoup. Contrairement à Guerrier, she is from the other side, giving care. And she will try to show how deep is the inequality in access to care in our Canadian system. Dr. Bryan, where's Dr. Bryan? Dr. Bryan will talk about the registry. And comme je vous le disais tantôt, registry is very important for, please sit down, for researchers, as well for also general population to know how, comment est-ce que la maladie évolue, c'est quoi les caractéristiques, qui est concerné, etc., etc. Elle va essayer de nous mettre en lumière, en perspective, tous ces aspects-là. And please, you are welcome to pose any sort of question. Je vous laisse la parole. You can start Dr. Simpson, and then Dr. Pakhale, and Dr. Bryan. Go ahead, please.
So I wanted to start with brief land acknowledgements, and it's with humble acknowledgements of the opportunity and responsibility with which I endeavor to serve the children and families of the unceded territories of the Anishinaabe-Algonquin region. I have no conflicts of interest to disclose, and so this is a brief presentation, but there are 3 objectives, and I'm hoping that by the end of the presentation you'll have a better understanding of the basic biology and pathophysiology of sickle cell disease, that you'll be able to describe existing therapies as well as newer therapies that have come down the pipeline, and that you'll have a better ability to discuss the current and emerging curative therapies that are available for sickle cell disease. So I'll start with a brief overview just to make sure that we have the same foundation in terms of our understanding about sickle cell disease. And so to give a bit of history, it was in 1910 when a dental student from Grenada ended up at Chicago Presbyterian Hospital with symptoms that about 1 in every 600 African American live births will be affected by sickle cell disease. In Canada, we currently don't have precise estimates of the incidence and prevalence of sickle cell disease. We estimate that there are about 6,000 affected individuals in this country. And based on OHIP data in Ontario, we estimate that there's a prevalence of about 1 in 2,800 children with sickle cell disease in this province. As you've heard, there are ongoing initiatives to establish patient registries, which are so important for us to have a better understanding of the condition and its natural course here in our Canadian context. With respect to the epidemiology across the globe, when we look at sickle cell disease, so in the map in yellow, that is the distribution of sickle cell disease across the globe. And you can see that although it predominantly affects Africa and the subcontinent, you can see that there are areas in Asia as well as in Europe where individuals are also affected by sickle cell disease. In the map below, this map represents the distribution of malaria across the globe, and you can see that there's a very clear overlap, which is likely related to the fact that sickle trait will confer protection against malaria. But knowing this, it's important to remember, and I always remind my patients of this, that sickle cell disease itself carries a more severe risk of malaria and can actually cause very significant disease with infection. So it's been alluded to already, but here in North America, sickle cell disease primarily affects the Black community, and this is because of the legacy of slavery on this continent and in this country. However, as I mentioned on the map, you'll see that sickle cell affects individuals of South Asian, from Mediterranean, as well as individuals of mixed ethnicity. So as a clinician and as a teacher to learners in medicine, I always teach that when you see an individual presenting with extreme or unusual presentations of pain, sickle cell disease should always be in your differential diagnosis. So when it comes to the spectrum of disease severity, the more S you have, the more severe disease you'll have. So individuals with sickle trait generally don't have manifestations of disease, but individuals with S-beta-0 thalassemia and SS disease tend to have the most complications and the most frequent presentations. So this is one of my favorite slides. I don't think I ever do a presentation without showing this slide, but this slide basically shows the pathophysiology of sickle cell disease. And so we know that it involves the sickle crescent-shaped red cells that lead to vasoocclusion. However, there are other aspects of the condition that lead to the complications. So here we have a red cell that's undergoing hemolysis, where the red cell's breaking down, and in doing so, it releases hemoglobin that scavenges something called nitric oxide, which is a natural relaxant of blood vessels. So as a result, individuals with sickle cell disease end up having higher tone in their blood vessels and are at risk of something called pulmonary hypertension in the lung. Under low oxygen conditions, you have sickling of the red cells, which is irreversible. And that, as you can see in the image here, leads to blockage of your blood vessels, which prevents oxygen from being delivered beyond that point. One thing we often don't talk about or think about is the involvement of white blood cells in the pathophysiology of sickle cell disease, where these white blood cells actually lead to more adhesion and sticking in the blood vessels that leads to that blockage. So here in this diagram, these are different points at which we can try to target our therapies to try to mitigate or decrease the complications related to sickle cell disease. So as Mr. Guerrier was saying, wherever blood flows, sickle cell goes. So sickle cell disease is a multi-organ disease that results in acute and long-term injury. So it can involve the lungs, the heart, the bones, the brain, the nervous system, the gastrointestinal tract. And you can have pain and complications involving any part of your body. With respect to the management of sickle cell disease, Because of comprehensive care, we've come a long way, but we still have a long way to go. When we speak of comprehensive care, we refer to the specialized sickle cell clinics that we have in major cities across Canada. We also have aggressive pain management, which isn't optimal, where we see that in pediatric centers, we do our best, but many of our patients, once they transition, may experience more delays in their therapy. We also are aggressive with vaccination to prevent infections and manage fever aggressively to prevent our individuals from sickle cell disease having severe infectious complications. So I'm going to spend a little bit of time talking about disease-modifying therapies. So I hope everybody here, or most people here, are aware of hydroxyurea, which is an old medication that was first described to improve outcomes of sickle cell disease about 50 years ago. But in Canada, we still don't have alternate therapies that are available to our patients. Chronic transfusions are options that we often offer to patients who don't have an ideal response to hydroxyurea or who have severe complications such as stroke or increased stroke risk. But there are novel therapies that have been approved in the United States that I'd like to talk about a little bit today. For curative therapies, there's bone marrow transplant as well as gene therapy that have become available. So as we've heard, the life expectancy of sickle cell disease has improved over time, and this graph comes from the CDC in the United States, where you can see the purple line, which represents the life expectancy for individuals with sickle cell disease, has improved and is approaching that of all Americans. However, this is not good enough, and this is because of limited therapies, social determinants of health, and inequities in care related to racism and other challenges that primarily affect individuals from Black and racialized communities. So for disease-modifying therapies, again, back to this slide, we're able to target the different points that are highlighted here with the yellow circles. Hydroxyurea is a medication that actually targets all of these areas where you have an increase in fetal hemoglobin, which replaces the sickle hemoglobin to give healthy red cells. And as a result, you have less red cell breakdown or hemolysis, but you also decrease those white blood cells and that stickiness that leads to the vaso-occlusion that I described. Another possible mechanism for hydroxyurea is by decreasing that increased tone I talked about in the blood vessel to reduce complications like pulmonary hypertension in individuals with sickle cell disease. So in talking about these different points of intervention, L-glutamine is a medication that helps to decrease the hemolysis that occurs with sickle cell disease. Anti-sickling agents are actually able to decrease that sickling and decrease that vaso-occlusion that's caused by those irreversibly sickled red cells. And anti-endothelial therapies decrease the stickiness of those white blood cells that lead to vaso-occlusion and perpetuate the complications related to sickle cell disease. So I don't have a lot of time left, but I wanted to talk about the different medications. Firstly, L-glutamine. So this is an amino acid that can be taken orally, and it's able to reduce the susceptibility of red cells to oxidative stress, which basically means high stress conditions where red blood cells tend to break down. So L-glutamine actually decreases that and also decreases that stickiness that leads to vaso-occlusion. So this is some data from a phase 3 clinical trial looking at L-glutamine, where there was a significant reduction in the pain crises, hospitalizations, time to first and second crises, and acute chest syndrome for individuals who were treated over 48 weeks. There was also a 25% reduction in the number of pain episodes. So this was seen as a very promising medication for our patients, and it's become available in the US. For anti-sickling agents, Voxelotor or Oxybryta is a medication that has become available, which actually decreases the tendency of red blood cells to form that crescent shape. And as a result, the red cells don't break down, and you have less anemia and less polymerization or sickling related to the sickle mutation. In the HOPE phase 3 clinical trial, they looked at Voxelotor compared to placebo, and they saw that patients had an increased hemoglobin. They had less red cell breakdown, but they did not see a difference in the incidence of pain over time. So this is a medication that's most helpful for individuals who have anemia as a primary presentation of their sickle cell disease, but it can be used in combination with other medications like hydroxyurea. So the next category of medications is anti-endothelial therapies, and a medication that's been approved from this class is something called crizanlizumab. So this is a medication that's given intravenously, and it's a monoclonal antibody that prevents adhesion or sticking to the red blood cell. So it decreases that vaso-occlusion and decreases pain episodes and similar complications. So this is a cartoon showing the vaso-occlusion that can occur with sickle cell disease. So you can see the gray cells there are representing white blood cells, and they're sticking to the red membrane or the blood vessel on the outer edges, and then sticking in addition to the red cells that are sickling in the middle. So when you add crizanlizumab, you actually have antibodies that bind to that P-selectin protein that normally would cause the sticking of the white blood cells that leads to the vaso-occlusion, and you prevent that from happening. And so this has been shown to be effective in clinical trials. So the SUSTAIN trial was actually a phase 2 clinical trial that showed a 63% reduction in the rates of pain episodes in individuals who were treated with a high dose of crizanlizumab compared to placebo. They did have a lower dose group, which was not any different from placebo. But it's important to note that there were increased adverse events for individuals treated with crizanlizumab, but this is primarily nausea as well as some abdominal pain, and this was very treatable. So here, I just wanted to emphasize that although these novel therapies have become available, they're not available in Canada. So L-glutamine was approved by the FDA in July 2017. Voxelotor was approved in December 2021. Crizanlizumab was approved in December 2019. And for L-glutamine and Voxelotor, this is for all ages, pediatric and adult. And then for crizanlizumab, this is for individuals aged 16 and over. When it comes to Canada though, none of these have been approved, and we don't have a sense at all of the timeline for these medications to become available for our patients. When speaking of curative therapies, essentially there are two classes. So the first is stem cell transplantation, and so this cartoon just explains the steps that are involved, where you have a donor who is a match, usually a sibling, with a potential recipient, and then stem cells are collected, processed, and then the recipient patient will receive chemotherapy to enable them to accept the donor cells, which then will produce healthy red cells and replace their sickled blood cells. So now that we have good outcomes with stem cell therapy, where overall survival is more than 95%, the goals now are to reduce the complications, the effects that we don't want to have. So there are two major trials that are going on in Canada. The SUN trial, which looks at reduced chemotherapy for patients who are undergoing transplant, and then the Sickle MAID clinical trial that looks at using mismatched mismatched blood donors for possible donation of stem cells. And these are going on in Alberta Children's Hospital and Sick Kids Hospital. So the next major category and novel therapy is gene therapy. And so there are two ways that this is done. Either the genes would be transferred using a virus that transfers a gene of interest. In the case of sickle cell disease, this is a normal beta globin, to stem cells that are reinfused into the patient. Or there's gene editing, where there's an ability for the recipient to receive cells that contain CRISPR-Cas9 that are able to edit their endogenous cells so that they're able to produce normal beta globin to replace the sickle hemoglobin. So these therapies are very promising, and so this slide just comes from a patient age 13 who was treated with gene therapy through a viral vector, and this was published in 2017. And the graph at the bottom just shows the gray line on the top of the bottom graph represents the total hemoglobin, which you can see increased significantly and was maintained for more than 15 months after the treatment. So this is a promising therapy. But again, gene therapy is only available to patients through a clinical trial. And that includes Canada, where even here at TOH, the Ottawa Hospital, they're opening a clinical trial looking at gene therapy for adult patients. However, for most individuals, they don't necessarily have access to a clinical trial. So here, again, although we've made improvements, we have a lot of work to do so that we can try to narrow that gap and have optimal outcomes for our individuals with sickle cell so they all have access to these novel therapies in Canada. So this means that we need ongoing advocacy and groups like this to help us to move the needle forward. So just a few take-home points. So firstly, sickle cell disease is the most common inherited disease worldwide. So there's no reason why sickle cell disease should not have the same amount of attention as cystic fibrosis. Comprehensive care has significantly improved life expectancy for individuals with sickle cell disease, but the truth is that in Canada, these comprehensive care centers tend to center in big urban centers. So that leaves a large community of individuals who may not in fact have access to the best possible care. In terms of medications and disease-modifying therapies, hydroxyurea is effective and it's safe, but there are other alternatives thanks to clinical trials where there are newer and effective options that will give better quality of life and overall health for our patients, but we have to advocate to have access to this here in Canada. So we need ongoing advocacy, ongoing clinical research, and continually pushing to improve access for effective therapies for sickle cell disease for our patients. And that's all I wanted to say. Thank you.
Thanks, Dr. Simpson. Very, very informative. Technical, but very accessible. I will propose to go straight with Dr. Pakhale and then Dr. Bryan, and we can pose a question to our three panelists. Dr. Pakhale, please.
Thank you for inviting, for this presentation. It really means a lot. Sickle cell disease has many facets, and I would cover some of them and try not to reproduce what Dr. Simpson had already covered. But most important points I want to cover is the healthcare inequity and the Canadian Sickle Cell Disease Registry that we have launched in April 2022. So first, I would like to acknowledge the traditional territories of Indigenous people that we live and work, and we pay respect and honor to the past and future generations. And I always say when I'm at the bridge that we are paying rent to the wrong owners. These are my disclosures because these are the funders for our research, so I would like to mention all of them, and they are all peer-reviewed funding, but otherwise there are no pertinent disclosures to my talk today. I would like to pay tribute. I work at the Community-Based Research Center, the Bridge, and we lost some members during COVID to the same inequities that we try to tackle at the Bridge through our research in the community, though we follow their legacy and try to walk in their shoes, carrying their dreams. So today, I would like to focus on these learning objectives to learn about the inequities, highlight some of the clinical manifestation, but I would try not to reproduce what Dr. Simpson already covered eloquently, and to advocate for the urgent needs for policy change. And I'm glad our senator is still here, intently taking notes, and to create the comprehensive clinical programs they are still lacking, they're non-existent, and to introduce the first and only Canadian Sickle Cell Disease Registry through this presentation. As you know, there are a lot of definitions of health inequity, and this is one of those. However, what we need to focus on is justice and going beyond that equity. And that's what we are lacking in the world of sickle cell, is the justice. And that's what I would like to highlight, what it means for us to be inclusive and equitable and just. So the sickle cell disease, we know, is an inherited disease with a single mutation, but it affects mostly marginalized, racialized community globally, not just in US and Canada, but globally, the most marginalized communities are affected. I come from India, and the same is true. The lowest caste people are affected by the sickle cell disease. So the prevalence, as you know, these are estimated numbers from Canada, and I hope we learn more. But the one most important statistics is about 80% people living in Ontario are belonging to the lowest third income quintiles. So they're not just racialized, but they are impoverished and poor and marginalized, and we need to take that account when we are creating any kind of program affecting sickle cell. And Dr. Simpson covered this. It's how inherited disease and what kind of severity the disease trajectory has, and it's a global disease. So I come from India, as I said, though in the African continent and India, it's very, very common, and we see that those immigrated or brought as slaves in the countries like US and Canada, the disease remains in the most marginalized communities. Though discovered in 1949, the gene, the point mutation, we still do not have treatments, and the parallel disease, cystic fibrosis that we are talking about, has a magic cure now. And this is because of the awareness, the funding, the policy changes, the registry-related data, and the knowledge that came out of it. And today we have a magic pill that actually cures cystic fibrosis. And we are far from there in terms of sickle cell. The pathophysiology, beautifully described by Dr. Simpson, so I would not reiterate everything, but the blood vessels, as they are throughout your body, and the lived experience shared before tells you the symptoms are throughout your body. So the clinical course is relentless pain, the manifestation because of inflammation, swelling of the limbs, feet, even present in little kids. The acute chest syndrome, I'm a lung doctor, so I will focus more on the lung. The acute chest syndrome, that common presentation in the emergency room, and the organ damage, because blood vessels are throughout your body. So multi-organ disease, just like cystic fibrosis, and yet we have so much difference. It affects the pregnant women, and the manifestations are devastating. It limits the life, and people die prematurely, and life expectancy numbers are again the guesstimates, because we do not have a registry data, we do not have prevalence data, we do not have life expectancy data in Canada. These are all just estimates, and we need to stop estimating, and we need to have real data. So pain is very important, as we talked about, and pain is pain. Like earlier we heard, it has no first name or last name, it just hurts, and we need to listen to the patients, and we don't do that enough. Lung manifestations, as I was saying, the acute chest syndrome, but I want you to take home this message that over 90% patients living with sickle cell has abnormal lung function. And we don't talk about it enough. And that abnormal lung function is an independent risk factor for dying early. And they relentlessly keep dropping lung function at much higher rate than the general population. And these, when your lung function is low, you cannot exercise enough, you cannot participate in your day-to-day activities enough, and your quality life is impoverished. So the acute chest syndrome is the commonest presentation in the emergency room when we see the sickle cell patients. So they present with chest crisis, pain in chest, different presentation, but many of our patients suffering from sickle cell also has asthma. And we need to understand the presentation of asthma, shortness of breath, wheezing, etc., and which is a hallmark sign of asthma, but many of the patients are not diagnosed with this kind of an entity, which is otherwise commonly known and can be easily diagnosed. But we do not have comprehensive centers with multidisciplinary specialists available at one site, and hence the diagnosis is delayed, and what leads to the delayed diagnosis, not just the more acute chest crisis. If your asthma is not diagnosed and not treated properly, you get more acute chest crisis and more drop in lung function, which is lifelong. So you keep paying the price. So the asthma and sickle cell disease story is still not fully known. I here have started my own sickle cell lung clinic, and this is it. My comprehensive clinical care is me, you know. And when I see the cystic fibrosis clinic, we have a dedicated nurse, we have a dedicated social worker, we have a dedicated pharmacist, we have dedicated nutritionist, we have dedicated doctor, not just a lung doctor, but we have a diabetologist, we have an ENT specialist, we have gastroenterologist, and we do a comprehensive multidisciplinary care clinic for cystic fibrosis. Where is that for sickle cell? We don't have it. It's not existing. Hematologists are seeing their patients in hematology clinic. I am seeing my lung patients in my lung clinic. We do not have multidisciplinary comprehensive clinical care. That is sorely lacking for sickle cell, not just in Canada, but also in the United States, because the funding is very poor, you know. But if you treat asthma in a sickle cell disease patient, their lung function improves, their chances of going to the emergency room are reduced, their chances of getting hospitalized are reduced because they get less acute chest crisis. And these statistics are very straightforward. And the disease is very similar to cystic fibrosis, inherited, multi-system, life-limiting, damaging multiple organs. But the difference in the resources and funding, what is available for the patients or for the research, is unbelievable. So the decline in lung function continues if you do not, similar to cystic fibrosis, you know. During COVID-19, we heard in the beginning, we did not know, but then there was some effort and some people started collecting data and they learned what people like Biba already knew, that people with sickle cell do get more COVID-19, a severe disease, and they are more vulnerable to get that disease. And that was then known after some research was done. But people living with sickle cell already knew that, how vulnerable they are to get any infection. What's different with COVID-19? And that's what came out of the data. They have higher risk of hospitalization. And the treatments are limited, Dr. Simpson told, very limited. And even those treatments which are available just south of the border are not available in Canada. So I hope people like Senator, I don't want to put you on spot, but you have another bill on your desk waiting to happen to get these treatments approved in Canada, you know. And unless people like you take on that, task, it will never happen. We will not have those treatments already approved by FDA here in Canada. We need champions. Otherwise, people just have to take the blood transfusion, which is a very, very devastating kind of a treatment itself. It has more side effects, and people just have no other options. Penicillin prophylaxis works, but it's only possible in younger kids, and the older people, we have only option is hydroxyurea. And so on and on I can go. These are the treatments available. They are very expensive. They cost you a hand and a leg and a foot maybe, and they are not accessible to many. People living with sickle cell are poor. People living with sickle cell belong to the lowest socioeconomic strata. They do not have voice. And hence we have to join our combined voice to create the advanced treatments and make them available if they are available south of the border. And these kind of treatments, which are, organ related, like specific treatment for lungs, when they get obstructive lung disease, when they get all these sleep related diseases, pulmonary hypertension, we have no treatment available. We have no guidelines available. And we need to learn these diseases further and create treatment options and create guidelines how best to treat these, so that my other pulmonologist colleagues know how to treat these people. And more research means more resources. We need more resources for research. Research doesn't happen without money, you know. The asthma needs to be well treated, but we need those kind of a comprehensive, multidisciplinary clinics that are existent for cystic fibrosis. We do not have that. And then only we'll be able to identify the asthma in sickle cell better, and we will be able to diagnose better and treat better and prevent the long-term lung complications. So these kind of treatments we know the pain crisis happen, we know they get organ damage, we know we can prevent so much, but we do not have those opportunities. We do not have those solutions available because of a lot of different things. How to reduce discrimination, how to reduce racism. If anybody has an idea, we can do a spin-off company from Ewurabena. because that's what we need to do, right? And there are financial and psychosocial burden, like earlier it was alluded to. We have a lot of angles to sickle cell management, and we do not have comprehensive solutions. We have profound healthcare gaps we were talking about in terms of people who are suffering from sickle cell, and thus we need more resources, more humanity to reduce the stigma, more humane solutions to reduce the stigma. Because the stigma affects multifold their clinical care, their outcomes, their day-to-day life in the community, not just in the hospital. The stigma prevails everywhere. And I, whatever can say here with my hands in the air, Dr. Beogo has very eloquently stated how sickle cell patients are impacted by this discriminatory behavior of our society towards people, but also the neglect of sickle cell disease that we see through our... So where we go from here, we got increased funding. We need screening programs, we need registry, we need preventive therapies, we need health education, we need more of awareness events like this. We need to reduce the stigma. We need to increase allyship and collaborations, We need to promote and create the models of comprehensive multidisciplinary care exactly like cystic fibrosis. We do not have to reinvent the wheel. We have the model. We just have to follow it. We need funding, we need people to follow that model, and we will be there. We already have a model. We do not have to reinvent the wheel. We do it so well in cystic fibrosis that we have come to a level that we have a magic pill now. They just take one pill and the cystic fibrosis is almost cured. Today's cystic fibrosis clinic doesn't look the same how it was even last year. And we have come to there not by accident, but by collective effort. And this graph was shown by Dr. Simpson, but I am wanting to tell you why that graph bent is because when the US did investment. Money brought that graph to bend upwards, the life expectancy, So this is very important. So the multidisciplinary clinic works. They have shown to work in sickle cell and other places, but we have the formula from, cystic fibrosis. The transition of care is important, and that's where I come to registry, because cystic fibrosis has registry for donkey's years. They learned so much from the registry, and now that we have launched the registry, we want to use it for multiple of these aims so that we learn more and we catch up with cystic fibrosis sooner than later. I wanted to show you just 1 minute clip of the registry, how it works, and it will have a, can you put play, please? Thank you. And it will have a simple interface where clinicians and nurses in the clinic will be able to enter the data when they see the patients after obtaining the consent. We will have the socio-demographics, we will have different questionnaires which will measure the test and quality of life. We will have separate patient portal where patients can input data, and we will learn much more from the input from the clinical team and all the patients, the living people living with sickle cell, and we will have all these rich data from all the patients across Canada. And when we will, just tiny bit, and we'll have different languages, and we then can learn so much more from the sickle cell that we have model of cystic fibrosis with the registry from US and Canada and globally, and we will get there from the registry starting here in Ottawa, going across Canada, and then globally, because we have the leaders like Biba, who actually is passionate and a warrior, not just a warrior, she is the leader who will be inspiring all of us to get there.
Thank you. Sorry for interrupting the talk. I would like to say something about the registry, okay? So I'm going to share some personal information with you. In my other life, I used to work for Statistics Canada. And how I started to become a public servant is that I was doing data collection. And one of the things they taught me in my training is that every time the government of Canada takes a decision about healthcare, education, housing, it comes from that information that we collect. I went all the way to the Inuit land and I collected data. And I remember they told me that every single decision that the government of Canada will take for the next 5 years rely on the information that we bring. That's it. So the registry does the same for us. That's our tool to show the quality of the care, to show the quality of life, and to tell them what are our needs. And it's also the best tool for the physicians to treat us. I remember when my son was going to college, he was in Sudbury. There was no physician to treat sickle cell. Nobody. He had to come back and cut his studies short because there was nobody to care for him. If there was a registry, maybe there would be more knowledge and expertise and experience sharing to help the physician over there. So I want you, when you go home, you go to your senators, you go to your MPs, and you tell them, in Canada, we need a national registry for sickle cell disease. What? She started here, we have to expand it nationwide. We want a pan-Canadian one. We want the information to be reported so that we know it's going to bring clinical trials, it's going to bring the new drugs. And I'm very happy to say that the first pharma to support us in this registry is Pfizer. And Pfizer is here today, so we say thank you. Thank you. The first to believe in this project and support us financially. Others are coming on board, where we need multiple partners. We need the government to come and support, because you know what? We're Canadians. So they have the responsibility to give us that tool that we need. So thank you so much. And she's the first one, you know. I don't know how many emails and Zooms and phone calls, and in the middle of the night, anytime I text you, you call back, you explain things to me, and then we've been having multiple meetings, and it's gonna happen. Because now, the Canadian hematologist also, CanHim, has come on board. We've had the first meeting, and they said, yes, we're gonna work on it. So my hope is, by next year, if we come back, we're gonna just come and start reporting on the data that we've collected. Thank you.
Thank you so much to Biba, to Schwab, to the organizers for today. I very much appreciate the opportunity to be here speaking with you on behalf of the University Health Network Emergency Department Sickle Cell Working Group. So I'm going to be speaking about the work of many people today. Oh, maybe I don't know how to do this.
Yeah.
Did I vote something up? Yes, okay. So I wanted to acknowledge the financial support that we've received from the University Health Network, Physicians Council on Quality and Safety, and the UHN Summer Research in Emergency Medicine Training Program. I'm mostly just guessing at the buttons. I'm also okay just to talk.
Ask to Michael.
So
Ask to...
I'm going to tell you a little bit about where I work. So I'm an emergency physician. I work at Toronto General Hospital, Toronto Western Hospital. The Toronto General Hospital is home to the largest red blood cell disorders clinic in Canada, maybe North America. And so we become the home emergency department for one of the largest populations of folks living with sickle cell in all of Canada. And this one here, oh, thank you so much. All right. And as we've already heard, significant barriers to care in sickle cell that are amplified in the emergency department. And here I want to acknowledge my collaborators, and I'll speak a little bit more about them in a few moments. But I wanted to point out that this is a mix of emergency physicians, nurses, learners, sickle cell warriors, allied health, and that really nothing can move forward unless we're moving forward together, which I think has been the theme of what we've been hearing so far today. Now, many of you may have seen this article in the Canadian Medical Association Journal in 2020, and this featured my colleague and now friend, Ms. Serena Thompson, who is a sickle cell warrior. And she called out that her relationship with the emergency room is that there is no relationship at all, right? As an emergency physician, I want people to feel comfortable coming into the emergency department. Ideally, I want people to not have to come to the emergency department, but when it happens, I want them to know that it's a safe place to come, and that really has not been the case for so many people, particularly adults living with sickle cell. Our emergency department in 2020 looked at ways of really taking an anti-racist stance as a department in a very practical way, and identified care of people living with sickle cell as a gap in our emergency department. And so we came together with our community organizations like the Sickle Cell Awareness Group of Ontario, the Sickle Cell Association of Ontario, with our nurses, department leads, with sickle cell warriors, with our social workers, with patient relations, with our hematology team, and other representatives of the Red Blood Cell Disorders Clinic to talk about what can we do to address some of these gaps. So what are we missing? What can we do better? And it was very clear that the #1 target was about early adequate pain relief in the emergency department. And what we knew is that if we address pain early and well, that it leads to shorter stays in the emergency department and a lower likelihood of having to be admitted into the hospital. And so this was important to our sickle cell warriors, it was important to our department, it was important to our hospital, right? So our interests were all very much aligned. This is the clinical handbook for sickle cell disease vaso-occlusive crises or vaso-occlusive episodes for Ontario that came out in 2017. And there are a number of suggestions in this handbook for how to optimize care, including very clear targets about time to pain medications in the emergency department. And so based on that advice and on extensive discussions, our aim was to increase the number of people who are receiving opioid pain medications within 30 minutes of triage in the emergency department. And we started off looking at how many people were actually reaching that target already. And what we found was that in 2019, the vast majority of people were waiting much longer than 30 minutes to get pain medications. Only 5.6% of people were getting pain medications at less than 30 minutes from triage. And we wanted to know, was this universal for people coming in with pain to the emergency department, or was there something different that was happening for people living with sickle cell? And so we compared with folks that were coming in with pain due to renal colic. So another very painful condition, bad kidney stones, not typically a life-threatening condition, so very different in that way from sickle cell. But we looked at the differences in time to pain medications. And so what you see in this chart it's a run chart starting from January of 2019. Every dot there represents the median, so the sort of middle time that it took to get pain medication. In blue for people with renal colic or kidney stones, in red for people with sickle cell. So looking at January 2019 to January 2020 to kind of get our baseline. And we'll come back to this. We took a quality improvement approach and started with a root cause analysis. So looking at the things that would help speed up getting pain medications and the things that tended to slow things down. The things that tended to slow things down, not surprising in an emergency department that we had overworked and limited staff. And there were also issues with obtaining intravenous access to be able to give medications in that way. And there were some gaps in terms of how people were being identified at triage as needing care. And so triage to a lower level than what was appropriate. We also saw two things that seemed to help get people pain medications in time. One was if people were getting pain medications before they were seen by an emergency physician. Now, we don't have at my hospital and in most sites in Ontario, we don't have the ability to have standing orders where a nurse is able to give opioid medications without a physician signing off. And so to me, when I see that someone's getting opioids before a physician is seen, that tells me that that's our nurses who are advocating for our patients. So that's the nurse at triage who's going to find a physician to say, hey, I know you haven't seen this person yet, can you just please sign off on this pain medication so we can get things started? So not surprisingly, that seemed to make a big difference in the timing. And the other thing that made a big difference was use of an order set. So we have, for a number of years at my hospital, had an order set that includes recommended doses for pain medications and suggested blood tests and when to do a chest x-ray, that sort of thing. And it's optional to use the order set. When people used the order set, people got faster care. When they didn't, it was a little slower. And so we focused on the two things that tended to help. So that nurse advocacy piece and getting access to the order sets and making use of them. We did three things in the emergency department. They, in my mind, are fairly straightforward things that can be done in any department. These are not cost-intensive initiatives. The first was identifying and trying to address the fact that we were very separated from the sickle cell community. So just like Serena Thompson had said in the Canadian Medical Association Journal, she felt that her relationship with the emergency department was that there was no relationship. And so we tried to tackle that piece by piece by having community building events, like the one that you see the poster for here, to give people the opportunity to talk to each other outside of the very high stress environment of the emergency department, to be able to hear each other's stories and get to know each other outside of those times of crises. We also adapted our order set, and surprisingly, for the first time, with patient warrior input. And so the order set now goes beyond doses of medications and suggested tests to include things like how important it is for folks to have access to distraction techniques, right? And so saying it's, if you see somebody who is having a sandwich or on their phone, it's not a sign that someone is not having pain. It could be a sign that they're actually trying to distract themselves and using strategies for managing pain that they've been learning over a lifetime of experiences. And so we've put that very explicitly into the order set along with that 30-minute target. And third, and I think most impactful, was patient and nurse-led education. So we had sickle cell warriors like Serena Thompson, like Marie Poku, like other members of our working group participate in education sessions in the emergency department to be able to give a first-hand account of what it's like to come to the emergency department when you're experiencing pain from sickle cell. And you can see in the mask, Nurse Ruth Biba Tinga, who to me is the epitome of a healthcare champion, who has really been working tirelessly with the working group to ensure that our nurses get educated about sickle cell in order to be able to do the on-the-ground advocacy that needs to happen. So I'm going to bring us back to the chart I showed you at the beginning. So in blue, folks with renal colic, and the time in minutes for them to get pain medications compared to in red, the folks with sickle cell, and this was from January 2019 to January 2020. And we looked after we started our interventions, and we were very encouraged to see this divide, right? So folks with renal colic, the time to pain medication stayed close to the same, and this is also before the start of the pandemic versus in the first year or two of the pandemic. And what what we interpreted from this data was that even in the face of a pandemic, using fairly simple interventions, we could actually decrease the time to pain medications in the emergency department, which was very encouraging. And so we went from having only about 5% of people that were getting pain medications within 30 minutes to about 15%. So there was a threefold increase in the number of folks that were getting their pain medications in time. And so yay, we did it, but I say yay, we did it, sort of, right? And so you also see in this chart that second red line that is trending right back up to where it was before, right? And that's to be expected with mainly educational-based intervention. But for us, it is a sign that we need to keep at it, right? That we need to go back. We've had a huge turnover in staff through the pandemic, so there is much more education that still has to happen. And there are other next steps that we want to take. We've got a new electronic patient record at our hospital, and we're looking forward to finding ways to leverage that to provide optimal care. We have increasing interest from our postgraduate colleagues, and so have 2 sessions dedicated for the future emergency physicians of Canada that are coming up this summer that we're encouraged about. And really, the bottom line is that we are going to continue taking steps together. So listening to our sickle cell warriors, 2 of whom are here in the audience today who are part of the working group. And so Alvin and Ulysse, I'm very grateful for the contributions that you've made to the working group. And again, this is, I'm sharing the experience of our emergency department. We still have an awfully long way to go, but by working together, we can make emergency departments the kind of safe and welcoming spaces that we all need them to be. Thank you very much.
Question? Don't be shy, please. Okay.
Bonjour et bonjour à nos panélistes. Et je m'appelle Mamoudou Kamara. La question que j'aurais en fait, ce serait pour vous, mais vous pouvez aussi anticiper. C'est qu'on a parlé tout à l'heure des médicaments qui sont malheureusement pas encore homologués au Québec, au Canada, je veux dire. Et j'aimerais davantage en fait, premièrement, quelles sont les raisons de Santé Canada. Et j'ai aussi entendu, si on prend j'oublie le nom du médicament en question, mais je sais qu'il y avait le semblant qu'on a au Canada, mais qui n'a pas plus ou moins au niveau du coût. Alors, est-ce que c'est une question de coût, puisqu'on a le même médicament semblable, qui n'a pas la même fabrication? Donc, est-ce que c'est une raison qui fait que Santé Canada hésite à l'homologuer au Canada?
Ok. Alors, je peux essayer de traduire en français ou est-ce que...
Non, oui. Donc, on va juste établir quelque chose pour la traduction. Quand vous parlez, vous devez arrêter au milieu ce que vous dites. Si vous faites 12 phrases, je fais un résumé. Un résumé, c'est pas bon pour personne. Mais si vous prenez une pause, je traduis, et ensuite vous continuez, et je traduis. Maintenant, je répète tout ce que vous avez dit. Vous voyez la différence? Donc c'est très important. Donc, est-ce qu'on peut commencer avec la première question que tu as eue? Parce que je crois que j'ai entendu 2 questions. Quelle était la première question?
Quelles sont les raisons que ces médicaments ne sont pas homologués par Santé Canada?
So what are the reasons that Health Canada has not taken those medications here and they're not available?
And so, there are a number of reasons. So most recently, COVID, the pandemic was given as a reason why COVID-related vaccines and medications were prioritized. However,
Par exemple, à cause de la COVID, il y a eu beaucoup de difficultés à avoir des nouveaux médicaments. Donc, à cause de la COVID, plusieurs médicaments qu'on aurait pu avoir ici ne pouvaient pas être disponibles.
However, like part of the reality is that some of these medications were approved long before the COVID pandemic happened. They were approved in the United States.
Et pourtant, la vérité est que ces médicaments, plusieurs d'entre eux, ont été approuvés bien avant la COVID, il y a bien longtemps, et étaient déjà disponibles.
And I think some of the reasons we've touched on through the various presentations this morning, where sickle cell disease is invisible to many people because of a lack of awareness, but also because of the way the symptoms manifest. And in terms of the community that's affected, this tends to be racialized and marginalized individuals. So for advocacy, it's limited.
Donc c'est pour ça qu'on disait que d'avoir la sensibilisation et aussi de militer pour l'anémie falciforme, c'est très important parce que le fait que cette maladie est entre parenthèses invisible fait que beaucoup de choses qui auraient pu être faites ne sont pas encore faites pour l'anémie falciforme.
So steps, sorry. Okay, I was just going to add one more thing. I was just going to say that, some of what Dr. Pakhale and Biba and Dr. Bryan were talking about today is you need numbers and data. So in Canada, for example, when we talk about the impact of anti-Black racism on healthcare, one of the arguments is that we don't have data. If you don't count it, you can't see it, right? So similarly with sickle cell disease, we need to have data to show our numbers, the needs, and the gaps so that we can better serve our patients.
Et pour l'anémie falciforme, on l'a déjà dit précédemment, c'est très important qu'on ait des données. Et avec ces données, on pourra demander, exiger et avoir des changements. Donc, par exemple, si on parle de racisme aussi, qui est un élément bien important dans cette équation de changement pour l'anémie falciforme, si on a des données sur ce qui se passe, on peut dire voici pourquoi on veut des changements, voici pourquoi on doit avancer.
Yeah, thank you. All those are very important points. I just wanted to add something related to cystic fibrosis again. All these drugs are very expensive when they come new and improved. But around the similar time, the magic pill I was talking about for cystic fibrosis was approved, and not just approved, it is available for the patients in the clinic today, and it is very expensive, like one tablet costing more than $10,000, one tablet. And so we are approving the drugs for similar kind of disease, which is rare and inherited, which is also expensive drug, and at the same time, we do not have approval for drugs which are actually less expensive for a disease like sickle cell. So all those issues we talked about, the racism, the discrimination, so we need more political will and people like our senator, and we need more patients' voices and organizations like Biba's and more to make that heard, and lobbying efforts so that we get those approvals, because there is otherwise no good reason for not to have them in Canada today.
Donc, je vais faire un résumé, malheureusement. Il n'y a par exemple pour la fibrose kystique, les médicaments sont déjà disponibles. Ce sont pourtant des médicaments très dispendieux, mais non seulement ils sont approuvés, ils sont disponibles avec le gouvernement, et ces médicaments ont été approuvés à des époques où l'anémie falciforme aurait pu être déjà approuvée. Et de plus, les médicaments pour l'anémie falciforme sont bien moins dispendieux, et pourtant on n'a rien. Donc c'est le temps vraiment de se mobiliser, de faire passer des lois et de demander des changements.
Hi, okay. So thanks for the presentation, pretty good talks. The question I have is, with the government having the rare disease strategy, I think this question is applicable to everyone. Like, what are your thoughts on, because we've talked about limited resourcing and funding for sickle cell compared to cystic fibrosis. Like, what are your thoughts on what the community can do to ensure that some of the funding from the rare disease strategy is actually applied for sickle cell, so to the registry, to work in the ER, to getting, better care for the community? Like, what are your thoughts on, and what are some ways we could, as a community, ensure that some funding gets into sickle cell?
Okay, so I'll take a stab at that question. It's an excellent question, and I think, you know, it has to be that we're at the table, you know, that representatives from the sickle cell community, whether it will be leaders from advocacy groups, clinicians, patients, caregivers, allies, they have to be at the table when decisions are being made about how the money should be spent. You know, data is important, but clearly, you know, having strong advocates who make the condition visible is really important. And so I think what we're seeing today, having people in politics like our senator invited to meetings like this helps to create that knowledge and awareness. So perhaps we need to invite individuals who have impact or influence on how that money is spent to be able to tell them the stories, to share the life experience, and I'm sorry you have to translate.
I will translate only for the people who speak French, one time.
Right, okay, all right, so everybody speaks English presumably. But anyways, just to say, we have to make sure that everybody who has a voice, or that we have a voice at the table, and that the people who make the decisions are aware of us and know that we also matter.
Il y avait une question derrière. On va prendre une dernière, ou avant-dernière question, parce qu'on est déjà largement en retard.
Oui, bonjour. Nous sommes des cliniciens à la cité collégiale, donc on travaille avec les étudiants. Et puis, j'ai 3 questions.
So we are at La Cité Collégiale, and we work with students, and I have 3 questions.
Wow.
Ma première question, c'est de savoir, comme M. Guerrier parlait du protocole, le fait qu'on ne faisait pas venir, est-ce que vous avez des collaborations avec certaines cliniques ou des centres de santé qui sont sensibilisés à l'anémie falciforme?
So do you have collaboration with clinics and centers who are aware of sickle cell disease so that there's changes in how patients are seen and treated?
Okay, ça c'est la première.
So that's the first question.
À Ottawa ou sont à Ottawa?
On va aller avec la deuxième, troisième.
La deuxième, c'est est-ce que vous avez encore des ressources pour ces personnes-là, parce qu'il y a une sensibilisation qui doit se faire, étant donné qu'il y a beaucoup de personnes qui ne savent pas. Moi, personnellement, je sais que je l'appelle drépanocytose. Le mot de l'anémie falciforme, c'est un peu nouveau. Donc, est-ce que vous avez des ressources pour pouvoir envoyer ces étudiants-là quand ils sont, par exemple, en crise, sans toutefois être balancés?
And do you have resources for students about sickle cell disease so that they can manage better and get better service, get better with their treatments? And she says also, I'm also puzzled with your word in French, anémie falciforme, because in Europe we call it drépanocytose, and we understand what that is. And when we hear anémie falciforme, we could be confused. So this is another comment she made during the question.
Dernière question, s'il vous plaît.
Et puis la dernière, c'est aussi pour les familles, parce que on s'occupe beaucoup d'étudiants, mais aussi des étudiants internationaux qui arrivent et puis qui ne savent pas où aller. Est-ce qu'il y a une sensibilisation qu'on peut faire à ces étudiants et puis qu'est-ce qu'on peut mettre en place pour eux dans nos écoles pour pouvoir les aider?
So I would like to know what can be put in place for students to help them, because those students who have sickle cell disease come, and what about them or their families?
Dr. Biba va nous aider aussi, elle va être malade en même temps. Mais vous pouvez aller vite, you can also answer to that.
I will add just a little tiny bit before Biba, because I don't want to follow Biba, because I know the answer is going to be
Je vais ajouter un petit détail avant que Biba parle.
So what I can say from my narrow scope of experience. So within the emergency department, I'm very fortunate that we're connected with the red blood cell disorders clinic at my state hospital. I'm part of. I'll stop there and then say.
Donc, je suis contente qu'au service d'urgence où je travaille, nous sommes reliés avec le centre. What center is that?
So University Health Network.
Donc, nous sommes reliés avec les services de santé d'université, le réseau de santé des universités.
Part of our protocol in the emergency department is that if someone is not connected with that clinic, that we send a referral so they can get connected.
Donc, on a dans notre protocole que si quelqu'un ne connaît pas ce réseau, il n'est pas connecté avec lui, on les met en contact pour qu'ils deviennent au courant.
But I would say the most important thing that I share with the sickle cell warriors that I see in the emergency department is information about the Sickle Cell Disease Association of Canada and about the Sickle Cell Awareness Group of Ontario and the Sickle Cell Association of Ontario. So being connected in the community, an incredibly powerful way to be able to advocate for yourself and your family.
Et lorsque je rencontre des patients, je les informe des associations en Ontario, des associations canadiennes, et il y a aussi une association au Québec. Donc on informe les gens des associations qui existent pour qu'ils aient un lien et du support.
And then I will happily
Et maintenant, on va laisser la parole à Biba.
Thank you. Exactly, that's what I was going to say, that I think the schools should connect with the patient group because we have some materials that we can share to educate about sickle cell, but most importantly to tell them on how to proceed to get care here because they're international students and it might be different for them when they're not Canadian. Our healthcare system, is different. And we've been contacted recently by many schools telling us that the students don't have the appropriate insurance and they find themselves with like heavy bills. And this is going to create another problem in our community again where they're going to be stigmatized, they're going to be left out, and they're going to even start refusing visa for them to come and study here. So we have to work together. We have, I think Quebec has a booklet for teachers also. Do you have it here today, Daniel? I don't know. Yes, and yes, this one is from Ontario, Sickle Cell and School, a guide to school policy and best practices. So you should get copies of this and you should connect. Recently, I was contacted by the school board in Quebec and I started meeting with them and we're creating a teaching program for teachers to know what to do and to know how to guide the students and send them. So, yeah.
C'est bon?
Oui. You want to say something, right?
Yeah, the first question was about the comprehensive multidisciplinary clinical programs, and we do not have them. They are non-existent. We are trying to create them, in collaboration with the pediatric hospitals in Ottawa, but multiple places, I know they do not have the multidisciplinary clinics like cystic fibrosis.
Et donc je voulais commenter que les cliniques multidisciplinaires avec des équipes composées de plusieurs professionnels n'existent pratiquement pas. Donc ce sont des choses à bâtir et à faire ici.
And about the advocacy, I wanted to say we should not be putting all the onus on the people living with sickle cell and their families, because I shared one statistics from Ontario that more than 80% people come from the lowest socioeconomic strata. They already have so many challenges day to day of survival, and they do not have that free time to do the lobbying and sitting in the meetings, and hence we need the allyship.
Et j'aimerais mentionner qu'on ne doit pas mettre tout le fardeau de la responsabilité de militer sur les gens qui ont la maladie, sur leur famille. Et j'ai mentionné comme statistique que 80% des gens qui ont la difficulté avec l'anémie falciforme ne sont pas socio-économiquement riches. Donc, les gens n'ont pas le temps de s'asseoir dans des réunions de cogner aux portes et de faire des téléphones. Donc, tout le monde doit être impliqué, pas seulement ceux qui sont dans le besoin.
Yes, I just wanted to make a comment about the Ottawa question, the Ottawa specific question you had. There are two clinics that I know of where they're family health teams, where they have a particular interest in caring for adults and families with sickle cell. So there's the Reform Clinic, which is on Bronson, I believe, Somerset West Community Health Clinic, where they have
On va prendre un break de 5 minutes.
Perfect, thank you. Good afternoon, everyone. I'm just setting my timer because I am a professor, and you know that we like to go on and on and on. And I have a flight to catch, so I can't go on and on and on today. So let me just set my timer. I just want to take this moment to thank everyone involved with putting this together, and all of the labor that went in, and all of the volunteers, and all of the ways that funds came together to fly us in, to have this food, and to make sure that we could have this conversation in this way. For any of us who do this work, we know that this is a lot of labor. It can be frustrating. You're up late at night. You lack sleep. You're eating out of cellophane bags. So I just want to say thank you for doing that work. My name is Dr. OmiSoore Dryden. I am the James R. Johnston Endowed Chair in Black Canadian Studies in the Faculty of Medicine at Dalhousie University. I'm also the interim director of the newly established Black Studies Research Institute that focuses on STEM, science, technology, engineering, mathematics, and medicine. And I am the co-lead of the Black Health Education Collaborative. But before all of that, I was a PhD student at the University of Toronto, OISE, and my research looked at blood donation. Most specifically, it looked at the kinds of stories, telling a humanities professor, the information that we were being told through the donor questionnaire, and how that information was deeply steeped in systemic anti-Black racism. I then went on to to map systemic anti-Black racism in donor protocols from 1940 until about 2020. So what I'm going to speak about today really is the systemic anti-Black racism that frames how we understand science, how we understand safe blood, how we understand equity, how we understand justice, and how we understand inclusion. Because if we do not understand how systemic anti-Black racism functions, then we will be invited to these tables, but nothing substantive will change. Yeah? There will be a call to increase Black donors, but we will not be able to create generational Black donors because systemic anti-Black racism has A, not been addressed, B, not been accountable for, and C, not been taken seriously. So that's what I'm going to map out today in 15 minutes or so. Oh, it worked. First, I want to say just a quick land acknowledgement. I currently live in Halifax, Shabuktuk, the traditional unceded territory of the Maliseet, whose ancestors, along with the Mi'kmaq and Passamaquoddy nations, signed peace and friendship treaties with the British Crown in the 1700s. What we don't often talk about with treaties, though, is that some treaties were signed before the end of slavery in this country, which means that not everyone is a treaty person, right? Because if enslaved Black people were written into treaties, we were written in as goods to be traded, but not as distinct people and the collaborative work we do. So I name that. I also want to name the distinct societies of African Nova Scotian people and Black Scotian people and communities in which I live, and to acknowledge that Black and Indigenous people are working collaboratively in spite of anti-Black racism and anti-Indigenous racism and the ways that we move forward. If we understand colonialism, then we need to understand that slavery was part of that, and systemic anti-Black racism precedes this work that we do. As always, Black Lives Matter, Black queer and trans lives matter. We are in the International Decade for People of African Descent. It's important to make sure we specifically talk about Blackness and that it does not get encapsulated in people of color or BIPOC, but that we talk about Blackness and we talk specifically about anti-Black racism, and in my research, anti-Black homophobia and transphobia. I just wanted to give a shout out to Amber Heights. I know there were rainbow flags are being flown all over at this time of the month. Happy Pride to everyone. But most specifically, I wanted to point to the black and the brown stripe. So Amber Hikes, as you can see, is an American civil rights activist and community organizer who serves as the Deputy Executive Director of Strategy for the American Civil Liberties Union. Amber was the one that added the black and brown stripes to the rainbow flag. And for doing that, she did it because we wanted to make sure it was more inclusive, that we were speaking about the anti-black racism in queer and trans communities. But in doing that, she received death threats. And we don't necessarily think about how anti-blackness works in queer communities. And so when we see this flag around, the question we need to ask is, great, we're celebrating Pride, but are they also talking about anti-blackness? Because these stripes are about how anti-blackness works in queer and trans communities. So are they being inclusive and talking about anti-blackness, or are they just glossing over that? So if we want to create an anti-racist donor system, and I think this is what we want to create, at least it's what I want to create, I think others want to create this, we cannot get to anti-racism without reckoning with anti-black racism. Even how we understand anti-racism today comes out of a history of black scholars, black activists, black interventionists. And so if we want to get to anti-racism, it's important to reckon with anti-black racism. My colleague, Dr. Ami Norm, and myself, we are the co-leads of the Black Health Education Collaborative, wrote this article that was published in January 2021, Time to Dismantle Systemic Anti-Black Racism in Medicine and in Healthcare. And I put it here because A, it was one of the first articles CMHA ever published, but B, this conversation around addressing anti-blackness in medicine and healthcare is one that's been happening for a while, but seems to increase after the murder of Mr. George Floyd, and of course what we were finding after COVID-19. So often people think of this image on your right, this image on your right. People think that this is what equity looks like, being objective and being colorblind. However, what you see in that image is if we're being colorblind, then we're actually not addressing the racism in the room. We are pretending that we're treating everybody equally, but we're not disrupting the racism in the room. Which means, as we heard earlier, these social determinants of health of racism continue to exacerbate our poor health outcomes. And what usually happens in that moment is then they rely on a race biology model. Well, it can't be racism, it must be because you're black, it must be because of your race. What we argue, what I argue and others, is that we actually need to see race. We cannot be colorblind. We need to see racism. And that is not objective. Often when we talk about anti-black racism, we're told we're not being objective, that we're being subjective. But in fact, if we're naming the elephant in the room, we've actually created conditions to make change, make substantive change, and hold appropriate people accountable. And if we're talking about anti-black racism, we're also talking about structural white supremacy. And we have to name how that is present in blood donation, in healthcare, and how that negatively impacts our kin, our family, who rely on blood products as a medicine. So I don't have time to get into this slide, but what I wanted to talk about here is that scientific racism and race biology, back in the day, was just called science. But there's ways in which we see scientific racism and race biology manifesting through the donor protocols from 1942 today, but also through Canadian Blood Services and the donor questionnaire that has been put into place that likes to conflate, that has conflated geography with race, and also the refusal to acknowledge how geography's conflation with race has worked to disadvantage Black donors unnecessarily so. Just a quick tip, if anybody in the room uses the word Caucasian, you are using a word that was created through scientific racism. And as we say in our training with the MCC, the Medical Council of Canada, the Royal College, and others, what you really need to say is white. Because Caucasian really comes out of these schools of thought of misogyny and polygyny. Happy to talk about that in more detail at another time. What is anti-Black racism? We need to acknowledge the work of Dr. Akua Benjamin, who was at Ryerson, now called TMU, who coined the phrase anti-Black racism to describe policies and practices rooted in Canadian institutions such as healthcare, education, justice. Some folks from back in the day may recognize anti-Black racism as something that Stephen Lewis used, but Stephen Lewis got that term from Dr. Akua Benjamin. It's always important to acknowledge the Black people who've been doing this work. So how do we support folks with sickle cell disease, family with sickle cell disease? What we do is we want to make sure that we have a robust donor protocol and process that is not using systemic anti-Black racism to weed out good donors like Black donors. Very briefly, so this man on the left, on your left, Dr. Charles Drew, an African-American man, cisgender man from the United States who came to Canada to study at McGill University. Dr. Charles Drew was an inventor and a scientist, and he created the technology that allowed for our donor systems to exist today in Canada, in the United States, and the United Kingdom. The images that you see in the middle are the posters from the very first public blood donor clinic ever held in Canada. Make a date with a wounded soldier today. At that time, that public blood donor clinic collected blood for the sole use in military, for military recipients. So if you had somebody in the hospital at that time, you would not have been able to access this blood pool. You would have had to negotiate with the hospital for a different drive. I put these two images together because they exist together. At the time, the Canadian Red Cross Society, which was responsible for, which is the medical military wing of the military, and also created the first blood donor clinic, public blood donor clinic. The American Red Cross Society and the Canadian Red Cross Society, following their neighbors to the south, stated that all the blood collected needed to be ethno-racially cataloged to make sure that white soldiers did not get blood from not white people. Dr. Drew, an African-American man, vigorously argued against that. However, the political will was to keep that unnecessary systemic anti-Black racism, that systemic racism, to ensure that white soldiers did not get blood from not white people. Here we see how systemic racism was embedded in the donor system from the very first inception of the donor protocol. Right? The image on the far end speaks briefly to some of the activism that happened during the AIDS crisis. At this point, you'll remember that there were groups of people, identities that were identified to say if you are gay, Haitian, a Haitian person, a hemophiliac, a heroin user, you can't donate blood. That is Haitian community members in New York, and the same protest happened in Montreal, that shut down the Brooklyn Bridge, shut down the stock exchange, and demanded that a scientific, rigorous protocol be put into place instead of focusing on people's identities. And they were able to change some of those practices. Even though there was a tainted blood crisis, understand what came out of the Cleaver Commission was the acknowledgement that a tainted blood crisis would have happened regardless, and that we should not be blaming that on gay people, Haitian people, people who use heroin, sex workers, that can go on and on. That is not scientific. That is not scientific. And so this piece is what preceded the creation of Canadian Blood Services, but also followed its way into Canadian Blood Services. That's called structural racism, which involves more than just individual prejudices or points of view. It refers to how society condones discriminatory practices and systems of oppression centered around laws, procedures, policies, protocols that codify preferential treatment based on race or racism. So this comes from my research. Again, my PhD is based on this research. I have a funded grant I completed a funded grant that extended this research. What you see on the right, or on your right, the gay and bisexual men, people generally knew that question, but not as many people knew the questions on the left, focusing people on Africa, whether or not you've had sexual contact with anyone from Africa. And so we move out of the Caribbean, we move to the continent. Again, this was claimed to be based on the science of the day, but in fact it was based on systemic anti-Black racism. And this has never been acknowledged by Canadian Blood Services. And part of accountability is acknowledging how the systemic anti-Black racism since 1998 to 2020 to 2023 has worked collectively to keep pushing Black people out of the donor system as opposed to bringing them into the donor system. So this is just a quick excerpt from the donor questionnaire from 1998 to 2005, where it focused on 8 specific African countries. The argument at this point is that there was a particular strain of HIV that did not have a test at that time, and so the only way to make sure that the blood system remained safe was to ban people or indefinitely defer those who came from this region that had a higher presence of this particular strain of HIV. That is the science that is claimed by Canadian Blood Services. However, that science also stated that that particular strain of HIV was present in Belgium, France, Germany, Spain, and the United States. But those questions were not included in the donor questionnaire. In fact, when asked about that, it was suggested by a CBS employee and by Health Canada that it's because the African people left these African countries and went to these European countries and brought that strain with them. That kind of anti-Black, systemic anti-Blackness always suggests that disease comes from Africa to European countries, and that disease doesn't go from European countries to Africa. It is how anti-Blackness works. So if the point at this time was that you could not test for this particular strain of HIV, then why not include all of the countries where that particular strain of HIV was included? And when you read this question, were you born in or lived in Belgium or the United States? Have you had sexual contact with anybody in the United States? Have you had blood products from the United States? You see how ridiculous the question sounds, and you understand that it's not scientific. But when you believe that those questions sounded reasonable when they only focused on African countries, then in that moment understand that you were buying into systemic anti-Black racism, because the questions don't sound reasonable. But instead of removing or changing that question, they instead expanded to read Africa. So when I asked about this, it wasn't, and I said, is it still based on science? The response was, oh no, it's just easier to ask the question in this way. So remember, Canadian Blood Services will say often we base this on science, but then said, we just made it Africa, all 54 countries, where AIDS is not an epidemic, right? AIDS is not an epidemic in all 54 countries of Africa. But it was easier to ask the question in that way. This is how systemic anti-Blackness works. And when I raised this, myself and some community members, with decision makers at Canadian Blood Services, and we identified that this was systemic anti-Black racism, we were laughed out of the room. After that, Canadian Blood Services uploaded these questions to the interactive computer automation. So now when you go, you fill up the computer, right? You touch the form to fill this in. When they first tested out that system, sorry, my heart's racing again. That's why I'm feeling a little breathy, sounding a little breathy. They added these images for these questions. Now, who does health promotion? Who's been involved in health promotion? Exactly. So when you add images, it is to clarify what the text says. If you add an image, right? Who's on TikTok? When you add an image, or when you add something in that way, it's to clarify, to provide further information about what it is that you're asking or what it is that you're educating on. These questions weren't a summer student that was told to Google Africa. These questions were approved throughout all levels of Canadian Blood Services and then ended up on the interactive computer program. There's only one other question at this time that had animals, and that was the questions about the green monkeys. Question that I still think is on the donor questionnaire and actually doesn't need to be asked. But when asked about this, they said, well, we thought it would be nostalgic. Because when you look at this is how people envision Africa. Living close to animals, living in vegetation, living next to dirt, therefore being diseased. This is how systemic anti-Black racism was encapsulated in Canadian Blood Services. And for something Canadian Blood Services has never been accountable for, has never taken accountability of. So anti-African, anti-Black racism would have us believe that disease in Africa and the Caribbean is natural. It is imagined that African people live in dirt, side by animals and vegetation. These are the kinds of images that facilitate Black people being scienced into degradation. And it's important to note that a reliable test for HIV, this particular strain, existed and was approved for use in 2009. However, Canadian Blood Services kept this ban in place until 2015, another 6 years. And CBS will say that the reason why they kept that in place is because Health Canada didn't approve this. And this is where we need to think about what trustworthy leadership looks like. I have a lot more information on my blog, so here are the QR codes, part 1, part 2. I wanted to identify, as I wrap up, I know I went through that quickly, I'm so sorry. Here, that's part 2, it'll take you to part 1. The next slide has statements and some reports where organizations like hematologists, like scientists, like Temerity School of Medicine, talk specifically about anti-Black racism. Canadian Blood Services has spoken about systemic racism, but has not specifically spoken about systemic anti-Black racism, nor have they taken accountability for that as far as I'm aware. So as I said, you can't get to an anti-racist system until you address and reckon with anti-Black racism. How do you build trust? The trust Black people have right now, and you'll hear more about this from Dr. Cénat, Black people trust that when they go to Canadian Blood Services, they'll be turned away. That's the trust that they have. So how do we shift that trust to actually be, no, we want you here, we will treat you respectfully, we'll treat you in a way, and we'll make sure that we are accountable for the harm that we've caused. Quickly, you really want to read Dr. Dana Watson-Creed's article in the CMAJ from the special issue, the 2-part special issue, on anti-Blackness and Black health on institutional gaslighting. I add this because you'll see a site here, there's a way that institutions like to undermine the work that we're doing. The one I highlighted is, oh, she's just an angry Black woman. She just does these things. These things have been said to me by various decision makers and to many of us in the room who fight for our rights. So we need a culturally safe healthcare system and a culturally safe donor system. Dr. Jean speaks of growing to create the National Coalition Confronting Anti-Black Racism and Donor Protocols. We had a webinar on World Blood Donor Day, which was June 14th, which is on the James R. Johnston Facebook page if you want to watch that. We have created an open letter which has about 30 to 50 signatures right now for Health Canada, Canadian Blood Services, and Héma-Québec, asking them to be accountable for systemic anti-Black racism. You can see our demands here. By building trust, we included the link, Anatomy and Apology, how to make an appropriate apology to Black communities across the country. Improving access, which is becoming accountable for anti-Black racism. Updating the question about malaria, which I did not even get to. Best practices right now is 3 years, as opposed to an indefinite deferral. Addressing systemic anti-Black racism in the various areas. And then, of course, effective knowledge translation, working with Black anti-racism experts. Sometimes people say systemic racism, but then never speak about anti-Black racism. It's kind of the inverse of all lives matter, without actually saying Black lives matter. If you really want to disrupt systemic anti-Black racism, you have to name it publicly, out loud, in your documents. effective change, provide a detailed outline for how they'll do that, and then of course schedule regular meetings with the National Coalition. I was funded by Canadian Blood Services for this project. Please email me if you want more information. And I also want to say this is where you can find information about the Black Health Education Collaborative. My apologies for in advance. I have to go catch a plane. I am so happy to be here. Please reach out to me. Biba, you are it. You are fierce, you are fire. We met at that CBS meeting, remember? And you've never let me alone since then, and I am thankful. And so for you, I give you my deepest respect, my deepest love. And Jude, you're my brother now, that's it, that's just how that's gonna work. I don't know if there's any questions.
We are able to just take 2 questions.
Yeah, 2 is fine,
First question, who want to go first? Who want to go first?
I know, it's a lot of information. And I want
Maybe one question,
Yeah.
Quickly. Are you able to see changes from the day you started work on this to today?
Yeah. I've seen some changes. I've heard from more Black people that Canadian Blood Services is reaching out to them. Canadian Blood Services doesn't reach out to me. And so I've just kind of heard it from Black folks. I've met with a lot of Black communities members who are like, how do we strategize around this? And my statement pretty much is the same, that if we are to have systemic change and grow and create generational donors, then the only way to do that, the best practice in doing that is around accountability, not just internally with their own staff, but also as an agency. And we've seen how that accountability has worked in other agencies by taking accountability for systemic anti-Black racism. Some of the kind of obvious ones are removals of the question. For sometimes people think if you just remove the question that the racism has ended, but you can't have that for 20+ years and not think that it's not going to have a residual effect. So yes, the questions have been removed, but that's kind of like the most basic thing you can do. But I am really excited about the ways in which Black communities seem to be thinking that there is more will from CBS to increase the number of Black donors, but collectively they have acknowledged that they still haven't seen an accountability around systemic anti-Black racism. So I think in this work, it's like a yes and a no. Yes, there's some things here. Yes, there's some things that are still outstanding.
Thank you for this excellent presentation, and I think it'd be so important for dermatologists and healthcare providers to hear more of this, so thank you. And I was just wondering, are there other jurisdictions we can learn from who've been successful at making these changes? Perhaps like in Europe or the United States, I don't know.
Yeah. You know, it was my U.S., you know, it works differently in the U.S., blood systems are differently, blood public systems are different in the U.S. But whenever I presented this in the U.S., especially when these questions were still live, folks in the U.S. were like, these questions aren't happening here, so what is going on? And then when I was speaking with researchers in Togo, in Cameroon, in Ghana, they had some really great questions on their donor questionnaire. But the African continent seems to be a place that Canadian Blood Services team in Quebec don't go to for best practices. So they'll go to Australia, New Zealand, the United States, but they seem to think that that huge, big continent in the middle is not a place where you can get information. But what I'm finding there is the work around HIV and therefore the work around blood donation and the work around malaria. They've created some really vibrant and excellent donor questionnaires, and that information is lacking and missing in this context.
I'm really sorry because we have to go. Biba, can you come? Biba, can you come to introduce Alvin? Oh, Biba, I will do it because we.
hello everyone. You are going to meet the warrior, my friend. Sometimes we love each other, sometimes we love each other less. Sometimes we fight, sometimes we agree, and when Alvin calls me and says, Miss Biba, I love it. I love what you did, and I know I'm on the right path. Because he's the ultimate warrior. I want you to listen to him carefully. If you want to know about what living with sickle cell disease is, you've heard Ulysse Guerrier, listen to Alvin. Friend,
First of all, I'm going to complain that Ulysse got like 20 minutes and I've been told I got 5 minutes and it started from the walkout. So I'll do my best. And as Miss Biba said, and I call her Miss Biba. Sorry, for those who understand, you call her Miss Biba or nothing at all. I'm a warrior, and I will leave it at that. An old warrior, even though I don't look it, so I'll just start off. 2 fake hips, a fake shoulder, laparoscopic cholecystectomy, liver failure by the time I was 19, revision in 2014, and a 3 by 3 centimeter hole in my left ilium crest. Those are for the doctors. ACS, acute chest syndrome, sorry, I gotta remember that. Not everybody here understands the language. Acute chest syndrome at least 30 times. I'm running through it like that because my speech was supposed to be about what it's like to live like that and what the daily life is like. I was lucky that I had parents who decided that the best thing for you to do is to understand your disease, and everything was a choice. So when Alvin was a Boy Scout, yes, I know that age, and approximately 48 to 72 hours in Algonquin Park in February in a tent. And as soon as I completed my Winter Gold Camping badge, I spent 6 months in sick kids with ACS and pneumonia like you wouldn't believe. But that's when you're young. When you get older and you make it into the workforce and you hear wonderful words now, like work-life balance, so to give you an idea of how old I am, I started working at the Bank of Montreal co-op during comp sci in 1996. So yes, I am that old. There was no such thing as work-life balance. And so to be getting sick every single month for about anywhere from 2 weeks to 3 weeks at a time, not every month by that point. At that point it was like probably like 3 to 4 times a year. You're getting sick 2 to 3 times a year, and you're missing 2 to 3 weeks each time, plus a week after that, because you're not just leaving the hospital one day and being back to work the next day. That's not happening, right? I was lucky, I consider myself lucky, that at one point in 2009, I was working for a great company. I got sick, and they were like, listen, if you want to do this little thing over here on the side, as long as you keep the clients with us, you can do so. So I've been self-employed since 2009, 2010. But what does that look like for somebody who's not as lucky as me? Or who's going to school like I did, and it took an extra year to finish school because you're sick, right? Like that's a regular thing for us, getting sick, missing time someplace, and not being able to get it back. But then you hear like these wonderful words, work-life balance, and it's okay, we understand. But then a month later, we're gonna have to let you go. You've missed too much time. My best experience, I will not tell you who the company is. For all of you, most of my experiences have been with the financial institutes, so I'm not naming the company, but you know where it is. Did the 3 months of training that you needed, but it was still under probation. I got sick the last week of probation. They brought my stuff to the hospital room. I did not make it through probation because of getting sick the last week of probation. That is regular in my world, right? You get sick, and if you're lucky enough, the company will ride with you. But how long do they ride with you? How many of them are really understanding, especially in this turnaround age of where like 1 minute you're working for one manager who seems to be cool, and you get to another manager who's absolutely not cool. And everything is about productivity. So as much as they say work-life balance, we need a body in that seat doing this job. And if you're not able to do that long enough, we're gonna let you go. That's one aspect. Now try having a relationship. So at this point, I'm single, Miss Biba still trying to marry me off. It's never gonna happen. No. I'm picky beyond picky, and at the same time, I no longer trust. I no longer trust because I've heard things like, I can't handle this anymore. And the first time that I realized that it doesn't just affect us, even though, of course, I'm the one on the bed in pain and a lot of things when my liver failed. And I ended up in a coma for 4 days, and I was in the Toronto General Emergency Transplant Step-Down Unit. And I woke up 4 days later, and my mom, who was a certain age when I went to sleep, was 10 years older when I woke up. And that's when I realized that my life affects other people. But I've had partners tell me they can't do it. They can't do it. They can't watch me like this. They can't be there for that. They need more. I've had dads say to their daughter, how's he gonna support you? Do you really want to spend your life taking care of him? I don't know. And it wasn't until I got older that I realized, so what I used to say, so from a very young age, I knew I didn't want to have kids, or so I thought when I was 11. Because in my brain, again, my parents were like, learn as much about the disease as you can. So I can have SS, partner with an AA, that child has AS, but then they need another AS, and boom, I can have a grandchild with SS. And I was like, no. That got tested when I was in late 20s, early 30s, and the partner I was with wanted another child. She already had one. She wanted another one. Found out men with sickle cell have low sperm counts. And I'm not going to say that it was the drug that I was taking at the time that caused that to then be permanent, so I'm able to have a child because of the medications that I've been on. Ms. Biba has also asked me to bring about like the mental health aspect of that. It can break you. It can break you to be in your mid-20s when everybody else is starting to get married, have children, live their life, and you're celebrating your birthday once again in the hospital because my birthday is at the end of the year. So it's, closer to winter. And you know what doesn't do well in the wintertime? People living with sickle cell. It's not a good thing. You then are losing jobs. You're losing partners, right? And you're adamant that you want to do it on your own. You don't want to live at home because I have family relatives who think my parents are absolutely crazy for allowing me to live on my own. And to give you a perfect example of a fight that Ms. Biba and I just had, is, so I had a foot ulcer number 6, it was. And being Alvin, I just ignored it. I was like, add it to the list. Pain, I don't even know what that word means. I think it's something that people talk about. I now use words like discomfort, right? And I'm not feeling the greatest. Miss Biba actually starts off the thing with, she knows not to ask me how I'm doing. She says, what's your status update? And then I give her a real answer. But the fight was, I got like really sick. Turns out I had COVID. It was Ulysse Guerrier who found out that I had COVID because he came over and he's like, listen dude, all you gotta do is take this little stupid test. And I'm like, right? But I had a fever of 104 for a couple of days, and my mom thought that the ulcer had gotten so bad that it had poisoned me and I needed to be in the ER. Every single time I spoke to a doctor, they were like, you're not getting any antibiotics from us. My mom, of course, she was like, don't you need a third opinion? No. So, me and my delirium Biba called me in the morning and she was just like, oh, what's going on? I was like, oh, Miss Biba, I'm not well. Talk to my mom. Never do that. Never, ever, ever tell Biba to call your mom. So, but of course, by that time, fever had broken, I was well. But Miss Biba calls in and she's like, oh, you know, I called, I'm going to mention a doctor's name here. I called a certain doctor, you know what, I can't do that because I realized his co-worker's in the back of the room. Biba called that doctor because my mom was worried about me having blood poisoning because of the ulcer. In the end, it was just COVID. But those are the kind of fights that we have, and that's the kind of life we live because, you know, people worry the minute you live alone. They're like, you don't have a partner. And I got mad at Miss Biba and my mom. I'm like, you wouldn't do this if I had a partner. And both of them were like, yes, you're right, we wouldn't.
And we told you something, because we are married and you don't have a child, you don't know how it feels to see your child.
Stop it. Sorry, the other person clapping is also that was involved in that situation. I don't. But that leads perfectly into the collaboration and why we also need things like the registry, right? I'm lucky that not only am I well versed in my disease and I know my body inside and out, and what changed it for me was yoga and acupuncture, something I fought for years because I was very scientific. I was always like, how is yoga going to change is it going to change my like sickle cells back into normal blood cells, and acupuncture is not going to do this and acupuncture is not going to do that? If I could go back and talk to 20-year-old Alvin right now and be like, get to that yoga studio now. The collaboration that happens between the organizations is something that is a must, and we should all look forward to making them stronger. And when I say organizations, I don't just mean the SCDAC with the SCAO or the Sickle Cell Circle of Manitoba or the Foundation of Alberta. I'm also talking about the ICBH, UHN, Sick Kids, the Ministry of Health. All of that collaboration is needed so that way we can finally find a cure. When Dr. Pat, I don't want to ruin your name or say it incorrectly, when she said there was a cure for CF, I was at the back of the room, like literally using language that's inappropriate for any recording, being like, how? Right? Like, there's a miracle pill, how? We are the world's oldest and most prevalent genetic disorder. And I'll say it, the reason there's a cure for CF that has less people affected by it than sickle cell, right? There's a reason why they have, like, the sickle, also as a patient, I'm also part of the Sickle Cell Association of Ontario as a board member. And I could tell you that what CF brings in donations would be, if you collected every single group in Canada, we don't make 10% of what CF gets in just Ontario. And that's collecting them all. And we all know why. We all know why. Because doesn't affect a specific set of people. Right? I'm trying to be as politically correct as I can. With all that being said, and also to make sure that I stay on time.
Already.
If you guys didn't hear what Miss Biba just said, she said I'm already over time.
Already 16 minutes. Already.
We need to collaborate better. We need the registry. The registry allows us, everybody's come up here and said 5,000, 6,000. I believe the real number of affected people living with sickle cell in Canada is 10,000. Ulysse and I are very sure that if you were able to really get into it, and I'm pretty sure the doctors know, like they have our blood work. I bet you if you were to get, it's closer to 10,000 people living with this disease in Canada. And I might happen to be on hydroxyurea, and some other people might happen to be using blood transfusions. But some of these new drugs that are coming out are definitely needed here in Canada for those reasons. Because some of us don't respond well to blood transfusions. That would be me. Some of us don't respond well to hydroxyurea. So then what are their choices then if they don't respond well to either of those two drugs? And hydroxyurea was not created with sickle cell in mind. It was a cancer drug that had some benefits for people with sickle cell. And blood transfusions is blood transfusions. We can go back to the days of bleeding a patient, right? That's all it is. But to end, consider the fact that when you see someone who none of you would have guessed what's going on the inside of this body, since you've probably seen me around anyway, that it's affecting us and our families in so many different ways. And we need all of your help. Every single person in this room, we are here to raise awareness. Do not be shy about it. And the shy about it part, I'm speaking directly to my community. We need to end the stigma, and Ms. Biba gave me a new word that she heard in a conference somewhere recently, and I'm going to use it before her, stignorance. Right? Yes. Stignorance. Let us end the stignorance about sickle cell. Thank you.
I think we need, we'll sing A Change Gonna Come. And I think it is really the song we need now. And right after we'll have the last panel.
I was born by the river in a little tent, and just like the river I've been running ever since. It's been a long time coming, but I know a change gonna come. Oh, yes, it will. It's been too hard living, but I'm afraid to die, 'cause I don't know what's up there beyond the sky. It's been a long time coming, but I know change gonna come. Oh, yes, it will. I go to the movie and I go downtown.
Somebody keep telling me, please, don't hang around. It's been a long time coming, but I know a change gonna come. Oh, yes, it will. Then I go to my brother, and I said, brother, help me, please. But he winds up knocking me. Oh, back down, oh, my knees. That I thought I couldn't last for long, but now I think I'm able to carry on. It's been a long time coming, but I know a change gonna come. Oh, yes, it will. Oh, yes, it will.
Okay, so we will proceed to the last panel, and we will be very strict with time. So I invite the guests to come along on the platform. Ok, donc Jude Mary Cénat et Biba Tinga vont réunir. And Dr. Walrond as well, please. Okay, so we will first hear from Biba, and then from Dr. Jean Walrond after.
Hello everyone again. So I'm going to talk about a project that we did recently. A project that I'm very proud of. It started with us as patient group engaging the blood operator, both in Ontario and in other provinces like Alberta, Manitoba, everywhere, making sure, but not Quebec, because Quebec is just Quebec. And then there's our Quebec group working with them directly. So we were engaging them, talking about blood, the need for blood for the treatment of sickle cell disease. And one of the things that we couldn't understand is that the donor base is so small, and we know that our community needs the blood to survive. We've heard it from people today, from the physicians, from the patients. And as we were working then, we decided to look, because I keep telling them, I don't understand. We Black people are about collectivity. So we talk, we go to churches, we go to mosques, we go to community events, we talk to our people, and they usually show up for us. But then the donor base is so small, so we don't understand, something is wrong. So that's when they said, okay, let's work together, people, let's look at the barriers. So that's why CBS brought some of its researchers. One of them, the wonderful woman by the name of Jenny Howe. She's not here today because she's attending a conference in Sweden. We initiated, and then it came also with the work that was started in Alberta by Dr. Jean Walrond, who started to look into these barriers. So we initiated a collaborative community-based project, the first one in the sickle cell community. First of all, I have to tell you about Sickle Cell Disease Association of Canada, who we are.
It's the national umbrella for sickle cell disease. SCDAC was founded in 2012 when we realized that there was a need to advocate at the federal level for some of the issues that we were facing. Organizations like the one in Alberta, the one in Quebec, and in Ontario were already in existence when SCDAC was founded. And whenever you see the red, that's where we have representation and we have member groups. So our goal is to just turn this map red and have a group everywhere working with us collaboratively. They are independent in their own process. They are independent, but they come to us and we set common priorities and we work together. I'm not going to tell you what SCD is, you all know what sickle cell disease is, but our mission is to be the national voice for sickle cell disease, and we advocate for the 6,000. Again, you've heard the numbers, 6,000, 5,000, 10,000, we don't know because we don't have a registry. So we advocate for newborn screening. When we started in 2012, just a few provinces were screening for sickle cell. Now, we only have 2 provinces not screening, Saskatchewan and Manitoba. And we're working on it. They will do it. Everyone is going to start screening for sickle cell disease very soon. And then comprehensive care, you've heard it also, better access to care and more research, for sickle cell disease. You've heard about the population affected, right? So it makes sense that sometimes some people will say, I've never heard about sickle cell. But for over 40 years, we've been left with supportive care. I said it before and I'm repeating it again. We've heard it from Ulysse, from Alvin. The state of the care for sickle cell disease is not the best in Canada. We need a basket of options to treat a multi-system disease. It doesn't make sense to have just 2 options for a disease that affects your entire body. And again, life expectancy is very short. But again, we can demonstrate it. We have 10,000 stories. I can bring so many patients and caregivers to share stories. But if we don't have a registry, we cannot really use the type of data that we can use to go meet our policy makers, our government, and tell them, here is the quality of the care, and here is exactly what the life expectancy is in Canada. So, before I go into that, I'm going to share a very personal story of how I became this health advocate. My son was born in Niger in sub-Saharan Africa. I like to say that we were at the door of the Sahara Desert. When he was born, he was a normal baby, and then he got sick around 6 months of fever. We thought it was malaria. Then we went back after 2 weeks, treatment didn't work. And then they said, well, he had yellow eyes, swollen fingers, and that's when they said, maybe it's sickle cell. So we got the diagnosis when he was about 7 months. But when I got that diagnosis, it was a death sentence. They did tell me specifically that he wasn't going to live. I will be lucky if he lives to be 5 or maximum 15 years old. That's what I got. And guess what? There was no mental health support. There was no thing. The doctor tells you point blank, you go home with your child. No internet. I had no medical background. No clear understanding of the language that they were using. No support. That's what was handed to me. This writing that you see is the actual writing of his physician. He wrote the blood type. He said, this is very important. You need to always know that. And then you can see his hemoglobin S was already 62.9. And he told me that F, which is the fetal hemoglobin, might change at some point and become either an S or an A, or an A. But in this case, it didn't turn to be an A, which is the good one. So what treatment option did we have at the time? It was blood transfusion every time we went to the hospital, hydration, because it's very hot, and warriors have to hydrate, and painkillers, that's all. And I thought, well, it's normal, that's what we have here, right? And we kept that boy alive just by doing what the physician told us to do. Sheltering him, blood, immunization, and blood when we needed it. But a few years in, all the time, I will see that the physician will give me this specific paper and tell me, Biba, I want you to go and take this test and bring me the result. The system is different. They hand it to you, you go get the test, and you bring back the result. And one day I was wondering, what is serology complex? In English, it would be complex serology. So I had friends who were in med school, maybe year 1 or 2. I went to them to say, what does this mean? They said, well, Biba, this is for another disease. They are testing for AIDS. I'm like, what? And you see the date? It was in 1992. He was a little boy. And I said, well, what's that? They go, this is worse than sickle cell. If he gets this one, he will die for sure, Biba. And I told him, I said, but how can I stop that? How can I prevent that? Because there is nothing you can do. That means he doesn't trust the blood he's giving your child. So every 3 months, he was testing for AIDS, and if he gets the AIDS, he will die. And if you don't give him the blood, he will die. So that's what it is. That's how I raised this boy. So when I stand today and say that we need blood, and I understand the need for blood for sickle cell, it didn't start in Canada. And at the time, the head nurse came to me and said, well, Biba, I think your son, we know which type of crisis he has. He has sickle cell anemia. He's going to need blood for the rest of his life. But here is the problem. We might not always have the blood he needs. So we have a deal with families. You go into your community, you get people to donate blood regardless of the blood type. And in exchange, we will keep the equivalent for your son because sickle cell crises are unpredictable. I was 19 years old and I was recruiting blood donors in Africa. Everybody I said, if you are strong, you look healthy, I will ask you, can you donate blood? When my friends were partying at 19 years old, I was recruiting blood donors. That's how we handled this boy, and we decided not to give him blood unless we had no choice. And by the way, do you know my son? He's in the room today. He's gonna hate me for this. Smile, can you stand up? So that created fear, distrust, mistrust, and those are the same things that I found in North America when I came. We immigrated to Canada. He was about 15 years old. They told me that maybe he might, die. So we got there. He was just 15 with a 3 years growth delay. But a miracle happened here. The physician at St. Justine said we can help him grow up with blood. And yes, they did. They gave him blood every single month for a year. And the man grew up like a mushroom. I'm telling you, the miracle of blood, it happened under our very eyes. But then it created other problems, iron overload. He spent years on medication for that. We were part of the first people to be offered the clinical trials for XJ when it came to Canada. And that's why I understand all the risk you take to get new drugs to Canada. By the way, as we advocate for the new drugs, they will not come because you want them. They will come when our community sits in the clinical trials, get the Canadian data that we can take to Health Canada, and then we can bring those drugs here. So that's why we have to be prepared. That's life today for him, and that's him. I know you hate this picture, but it is here. He goes to the hospital every 6 to 7 weeks. We need about 9 to 10 pints of blood, and we still painkillers, antibiotics, and blood transfusion. Hydroxy every year did work for him for 3 years, but then it stopped working. So now the only option left for him is the blood. So I understand it. And I've seen him have a reaction to blood transfusion. I've seen him go through the crisis of cellular change. It's scary. You don't want to experience that. It's a trauma that you can't forget as a parent. So that's where I came from. And when I advocate, when parents come and we go to the health operator, we understand that how important is it for the blood to be safe for everybody, not only for our community. We understand that. But what we are advocating for is to make sure that barriers are removed so that people who can donate blood do so that we can save the lives of our family members. So we need more African donors to come to CBS and Héma-Québec to donate blood. In Quebec, there is a great success done by Mr. Wilson Sanon because he was able to get Héma-Québec to go on Sundays into churches where our community is, and they're donating blood. CBS is not doing it yet. They are not really present in the community. But let me tell you something. With the work we are doing together, I see change. It has started. Because even the materials they are proposing is changing now. And this collaborative project helped us create a tool. As you can see here, these are the Felix brothers, and their dad is here. 3 brothers, 2 of them have sickle cell disease. They live here in Ottawa. They're already blood recipients. So look at the young generation. They're going to need it for the rest of their life. So we can't afford to sit here and continue to have a very small pool of donors. My own son is linked to about 10 people in his life that we know nothing about. I'm very grateful for the gift of life. But every single time I wake up as a mother, and I'm scared that what will happen to him if one of them moved out of Canada or decide to stop donating blood, or something happened to them, they get sick and they can't donate blood. What is going to happen to my child? That is a scary thought for any parent to live with. So this is why we start with the blood operator, and we did this positive collaboration with the community, and we look at the barriers. But what we did here, we look at the materials that was given in the community to recruit blood donors, why it wasn't working. I have to make a pause. Do we have Dr. Howe's presentation? Do we? We don't? Jenny?
No.
So the part where we present really the method and the work that was done was recorded by Dr. Jenny Howe, but she's away, and apparently they don't have it here, so we can't play it. But I'm just going to show you the recommendation quickly. This is what came out of the work that we've done. Be transparent about deferral criteria, because when you go in the communities to recruit blood, tell them that those who have had malaria can never donate blood. Don't let people come and get deferred, and then they live with this rejection feeling, and we can't get them back. And what happens is that the word is spread to the community, and others are not going to show up also to donate blood. You know, conduct research to ensure that the deferral criteria are minimally restrictive while maintaining safety. We have that Dr. Dryden mentioned. We need more research, you know, and then also show the process to people, because they don't know how, if it's painful, how it can affect their health, how long it takes. And they mentioned that, you know what, it's also financial. Some people don't have the time to take maybe the afternoon to go and donate blood. So that's why when we come to them after church, for example, on Sundays, they do have time to donate blood. Or if you drive to their communities where they live, because it's far from downtown, maybe they would donate blood. So have a presence in the neighborhood, you know, be visible. We don't see CBS in our communities. We don't see people who look like us in the ad, but it's changing though, it's changing. We've had a video from Ulysse, and then now there's a new picture with Andy, who is from has sickle cell. I've heard that people saw something in Scarborough, in Toronto, with Andy's picture, and they've been calling me and telling me about it. So change is coming. Now, these are the work that that's Andy right there with the red shirt, and we published an article in Transfusion, and we presented a poster at the conference, and now the tool that we've created is here. This is a recruitment guide that we want people who are recruiting blood donors to use when they go into Black communities, especially racialized communities, because it came from the people who are potential donors or donors themselves who told us what they like or didn't like. So CBS has launched also a website where specifically dedicated to sickle cell. We are going to share it through our social media today, right, as I sit here. And I want you guys to go. That guide is uploaded there. You can download it. We've also going to have some printed copies available. Send an email. We can send you. But that page is good. If people want to donate blood, tell them to go there and read. If you recruit them to donate blood for sickle cell, tell them that. And one last thing that we've done, when I became leader in this community, we gave every single province their PFL number. And the PFL number is Partner for Life number. So that every province in Canada, sickle cell group has their own number. And what it does is that if you register on blood.ca and you donate blood, that donation is attributed to sickle cell disease. First of all, it shows CBS how willing we are to work with them, you know, and make sure that we move. But also, it tells us that people are listening to us and our efforts, you know, are being, you know, done. So they asked me to conclude, and I've been doing that to Alvin, so I have to keep quiet. So thank you so much for your time, and I hope that those who can donate blood here will, when they leave this room, or they will recruit blood donors for us. Thank you.
Good afternoon, everyone, and I'm here to present to you. My topic is called "The Future is Bright for Research in Sickle Cell Anemia Disorders." but nothing about us without us. I speak to you today as someone who has Carib ancestry. So I am indigenous to Trinidad and Tobago. I also speak to you today because the indigenous people come from South America, the Caribbean, Central America, the United States, and Turtle Island. I also speak to you today because I celebrate Juneteenth. So happy Juneteenth to everyone. And this goes back to the fact that my genes, my African genes, survived the Middle Passage. So this is why I'm here speaking to you today. I stand before you today as a sickle cell parent with a PhD in education policy studies, where I focus on culture. I looked at culture with respect to Caribbean students who attended school in Edmonton, Alberta. I have been able to use that degree and transfer that knowledge to looking at sickle cell anemia as a health disorder with respect to how health is taken up in different cultures. So I am now the subject matter expert for sickle cell anemia disorder, cultural and social policy. Thank you. I am standing here today, and I'm just leaving on that slide there. I'm standing here today to put forward and to lobby the government of Canada to give us $25 million to conduct sickle cell anemia disorders research and sickle cell anemia treat. Here's why. If you look at that slide there, it talks about a cultural identity model. This is the model that I developed when I was looking at Caribbean Canadian students and how their education and culture is taken up in the school. If you look at this model, you will notice that what happens here is that the culture is taken and put into the outermost concentric circle. This is because culture is represented in each and every sector of our society, our community, and the different realms that we are not aware of today. So culture is part of it. You can take it out and see that I have positioned myself in the center, and then at the bottom you can see a sort of a black circle. That is because this is just a plain XY diagram here, but that black circle at the bottom represents all different people and how their culture is represented. So the different people in that sphere, those who have gone, those who are present today, and those who are yet to come, influences my cultural identity, and so do you, yours. So this is what I used. Now, if you can think about it, most people look at culture in the classroom, but think about culture with respect to the healthcare system. If you are not very familiar with it, you have a very relaxed quasi-interpretation of it. You will definitely not engage in that medical structure as others who are more used to it, more attuned to it. So the hypothesis is positive outcomes occur when individuals feel that they are welcome in a specific structural environment. Next slide. Okay, so the other problem I had was, recently I was asked to do a proposal for funding. And what I was asked to write about is nothing about us without us. I had to comment on that in my proposal. It turns out that this concept was taken up by people who were mobile, restricted, and so on. They wanted to be part of the discussion when anything is done about them. They wanted a place at the table. So, in asking for this $25 million, I think I have a right to do so, and here's why. Can you please go to slide? Keep going and I'll tell you when to stop. Okay. Biba, I think the slide is slide 6. Is it this one? Yes, thank you. Now, if you look at this slide, I know earlier this morning, someone spoke about the first person who looked at sickle cell anemia. What happened was that the young man came to Chicago to study dentistry. It was determined that he had sickle cell anemia, but that is not how it came about. The young man's name was Walter Clement Noel. He came from Grenada, and he lived from 1884 to 1916. Ernest Irons, who was an intern at the time, kept copious notes about this sickle cell patient, thus giving enough information to James Herrick for him to discover in 1910 the sickle cell disorder. Linus Pauling called sickle cell anemia the first molecular disease, and that molecule is part of our DNA. The molecule is found in, the errant molecule is found on chromosome number 11. So we look now at the discovery of dioxyribonic acid. This gentleman, Mercier, he discovered that human pus produced a precipitate in an acid solution and in a basic solution, and in an acid solution it dissolved. Now the thing about it was that he started to look at it, with lots of curiosity. But he did not get very far with it. The properties that he found, he wanted to do more information about it, and he found that the properties were parts of other proteins. And the pure form, he called it nuclein, and this is cousin. So when we hear a lot now about DNA, we also hear about RNA. So I explained this to my grandson, who is 8 years old. And I said to him, this is what a motif for DNA looks like. And when you pull it apart, this is RNA, RNA, when you bring it together, it's a motif. So it spins on both ends. So he said to me, oh, the DNA helix. And I said, yes, that's how you understand it. Now, Crick and Watson were the ones who named that double helix DNA. If you notice by the diagram here, you would see that the chap from Grenada, we don't have a picture of him. Now, the unit of your DNA is now called a gene. The Human Genome Project started in 1990. What they used were blood samples from Buffalo, New York. And I understand that the person that they looked at was African American and white. They came up with the mapping of the DNA, your genes. I call it the alphabet for your genetic structure. But there were some gaps in it. And Ptolemy to Ptolemy, the Ptolemy to Ptolemy consortium filled those gaps by March 31st, 2022. Leo said, well, this is a single genome, a project based on a single genome. What about the multiplicity of different people on our genetic diversity? So now, they suggested now we talk about a pan-genomic hypothesis in which 47 humanoids will be looked at globally to really fill out this alphabet. They are going to get the majority of those 47 people from the African continent. There is more variation in your DNA within the African continent than between people from the African continent and the rest of the world. Today, we have organizations such as Evitas, I hope I'm getting their pronunciation properly, looking at CRISPR-Cas12 in doing sickle cell research. Yet we hear so very little about what other research that can be taken up. We have heard everybody stand up here today and speak about a lack of funding. Now, we have contributed the basic molecule for looking at your genetic makeup in order to determine what is possible. One molecule breakdown on your chromosome 11 is responsible for sickle cell anemia. I love math, and if you have one variable that you're looking at, you can do substantial amount of research rather than looking at 10 and 12 markers on your DNA, which they are doing now. I want you all to go and check and see how many markers on your DNA contribute to cystic fibrosis, how many contribute to cancer. If we are contributing that much knowledge to genetics today, isn't it time that we demand $25 to $30 million to start doing research? In Canada, I found out from reliable sources that in the United States, they are looking for $500 million. When I contact people at a certain company that made Oxberta in the States, I contacted them to ask them, how come your medication is not up here? They said, well, we need to get approval. And I said, and how come we cannot even see it on American channels in the border, from the border they cannot advertise it because it is restricted in Canada. So, what are we going to do? Well, I'll tell you what we did with respect to sickle cell anemia in Alberta. During my reign as president, we got newborn screening for Alberta and Northwest Territories. Can you flip your slides now to one? No, forward. You just passed it. No. That one. Okay, if you look at that slide, it says that Sickle Cell Foundation of Alberta created an K-12 curriculum for African and Caribbean Canadian books. And it is an award-winning compendium, and it is in our library system. What we will eventually do is link K to adult sickle cell books, fiction and non-fiction books, and we are going to develop an app so we can have those books loaned out worldwide and take them back in due course so that everyone worldwide will have information about sickle cell, so we would not have these phobias because we're going to be educating them. The next thing we did, Biba mentioned the research that we did. We decided that we would have mixed methods research because I advocated to Canadian Blood Services year after year, and they didn't listen to me. So I went out and I got the funds. We did the quantitative part of that research. We looked at 110 individuals in our community of Edmonton. We found out that people did not know much about sickle cell and they didn't know much about blood donation. But they told me that they got their information from social media. So what we did, we developed an app. We developed an app so that we could get people to donate blood. This app now is already developed and it has to be brought into the public domain. It's called Michel's Pint Size app. The next thing that we have done is we have set up a legacy fund for creating a research chair at the University of Alberta for studying sickle cell anemia. I also work with sickle cell groups in the United States, and we have 2 projects coming up as I speak. The first is a faith-based initiative because we are going to go to all the faith-based communities across Canada and get them involved. We are going to be talking to the Center for Disease Control and getting the protocols on how we go about telling people to promote sickle cell anemia through their churches. We are also going to look at a post-secondary based initiative, and that initiative is going to be focusing on the historically black universities and colleges across the United States, their fraternities and their sororities, and we are also going to be going across Canada looking at all post-secondary schools, and we are going to be having them, the black campuses, involved in spreading our word. If anybody wants to hear more about what we're doing, that's my address and that's my email.
I know you are tired, so I will take less time.
Thank you all for speaking with us.
Yeah. And understanding systemic racial barriers to blood donation among Black people in Canada. But I found this part important to put. It is a citation from interviews we did. Our blood is not pure enough. Yeah, so, okay, so there are really three main motivations we have with this research. The first one is the fact that we received a lot of emails from people from the Black communities asking questions about different things, but also how the center will address this kind of aspects. One of them is someone who said we have to do something to stop them treating us like animals with impure blood when we want to give blood. How can you accept being told that because you are Black, because you spend your childhood in the Caribbean, you can't give blood, your children won't be able to give blood, your grandchildren won't be able to give blood? Does it take 3 generations to purify our blood? But also, the second motivation is the fact that we are doing that work with Sickle Cell Disease Association of Canada, but also because we were approached by CBS, Canadian Blood Services, to try to see how we can address barriers related to blood donation within the Black communities. And this, it was impossible for now to work with them because we don't want to legitimate anti-Black racism, and it was the kind of work is doing is not like the center, the leadership and scientific committee of the center had meeting, and we found it is not the way to go. We had a qualitative method, but we are at the beginning of analyzing the data. So what I will present today is really preliminary results. And the barriers we found, the first one is financial barriers. People who said, like, I have 2 jobs comparatively to my colleagues. I'm underpaid. It is difficult to dedicate time to give blood. So I think it is one of the things which is important, but also we can remark about systemic racism when people said they are unpaid, and we know Black people are unpaid in Canada for the same job compared to white people. But also anti-Black racism, and people will say, my brother who lives in the US donates blood. In Toronto, they say I can't give blood because I'm Black and I come from a Black country. And I will say some words about this because in the Wednesday workshop, last Wednesday workshop, we had a question from someone from CBS, and I want to answer to that question. And people say, you experience so much racism that you are afraid to give blood. The blood of many Black people has been refused because of racism. And even when it's the norm, the way it's said, you feel you are impure. So another thing is institutional and systemic racial discrimination against Black people in the healthcare system. And I think that part is important. Even, for example, one of other things we found was the lack of confidence. And I want to take this citation. Someone who said, during my delivery, I almost died because I wasn't respected by the health system. So why should I trust giving blood to people who don't respect me, who treat me with disdain and discrimination? So the racial discrimination in the healthcare system also impact the blood donation within the Black communities. But also there are religious aspects we have to try to study and try to examine and to better understand. But a lack of information, accessibility of blood donation centers, and I think the religious communities, they have a great role to play on this. In Montreal, for example, you have a lot of churches and they organize blood donation, and I think that works. But also prejudice and stigma in the Black communities about blood donation. People would think, like for example, oh, I'm too sick to wait to give blood, and giving blood, maybe I will be sick. And one of the things which was people talked a lot about was the belief that Black people's blood isn't really used by CBS and EMA Quebec. And a lot of people said, oh, like one of the things that, like, it is like things from people who were interviewed, and they said, oh, that's from someone who worked with, for CBS. Like someone who worked at the Canadian Blood Services told us, the blood of Black people is just for testing. They never give our blood to people. It's not worth giving blood as a Black person. So I think all of that barriers, we have to understand them and to know what are the impacts on blood donation in the Black communities. One of the things, and that I experienced it myself, and my wife experienced it also, like the lack of skill in injecting Black people. Like people said they pricked us many times. We don't trust their skills. Like they try to prick you, and many times, and they cannot find your vein. And it is something that is real for Black people. Myself, I experienced it, and my wife during the two deliveries, the delivery of our two babies, experienced it also. And also lack of representation in the healthcare system, and also in CBS and in Quebec. And a lot of people said, oh, we were in the blood donation center, we are the only Black people. And there was no Black nurses, and we were the only Black people. And I think all of this can help to understand. I wanted to say some word on the malaria issue because it was the question by the CBS person. First of all, to know it is the current risk in the US or in France is 1 out of 4 million for transfusion-transmitted malaria. 1 out of 4 million. For AIDS, even with the test, it is 1 out of 1 million. Yes, it is science. What I'm saying is about science, about that data. And in the US, England, Australia, France, if you have a history of malaria, you can donate blood. In Canada, you can't. Even the FDA, which is a well-known racist institution, and I'm I'm an Asian citizen, and I can tell you about FDA and how they were racist against Asian people. And even then, they took action to let people with history of malaria give blood, but not CBS and EMA Quebec. And I think it is very important to notice. And why we decided to do not participate in the CBS action consultation on this, it is because we discovered that CBS has data to take the right decision. They published they are from CBS. They published an article in 2019, and in that article, they explain about France, Australia, England, and the US, and also Canada, and they explain the situation, they explain the policies, and they also explain all the data and evidence about the data and why it is important to take action to remove like the permanent deferral, like you cannot give blood if you have a history of malaria. And in that article also, one of the things they showed was the key factors in decision making for the US now, the 3-year deferral, and for France, if you have a history of malaria, to test you for malaria. And they said it is like what motivates the decision is like the permanent deferral is political concern and regulatory concern. But we don't know that political concern. And we want to know what they are. And I think it is important. We also found community-suggested solutions, but I think I will take about them another time. But what I want to conclude with, because first of all, I'm a clinician psychologist, and a lot of people who tried to give blood, to donate blood, they also spoke about mental health issues when they faced like the barriers. And people who said, by fund, you will not be able to give blood. Your children will not be able to give blood. Your grandchildren will not be able to give blood by CBS because they are born in a country where malaria is endemic, or because they have an history of malaria. That people, they feel like they are very affected psychologically by this kind of declaration, of statement. But also, I want to note that the mental health of people with sickle cell disease in Canada, and I think the fact that for now, we have no study, like when I say no study on this kind of aspect, and I think it is important to have more research on this, and to also think like, it is not, we are talking about this, it is not because, I don't know, in the room today, a lot of people spoke about cystic fibrosis and sickle cell disease. And we never say the word, it is about skin color. And it is important to name it. It is about racism. If people with sickle cell disease if they were predominantly white, I'm sure we will have funding for research. We will have a registry, and we will have medication to treat it. Thank you.
Thank you, everyone.